फोटो भी उतर
Hello. Now I would like to invite Mr. Vikas Bhatia. He is the founder of MERD Foundation India and he will deliver a welcome address. Welcome, sir.
नमस्कार, वंदन और आप सभी का अभिनंदन। मैं विकास भाटिया, फाउंडर मेटाबॉलिक एरर एंड रेयर डिजीज फाउंडेशन मर्ड इंडिया। आज की इस सेमिनार में जो कि स्वस्थ बच्चे स्वस्थ राष्ट्र की परिकल्पना को लेकर है, उसमें आप सभी का स्वागत है। मैं सम्मानित महसूस कर रहा हूँ कि आप सभी का सानिध्य इस सेमिनार को मिल रहा है। हमारे बीच में आज कई प्रतिष्ठित व्यक्ति, संस्थाओं, डॉक्टर्स और कई ऑर्गेनाइजेशन का प्रतिनिधित्व करने वाले माननीय आज यहाँ पर उपस्थित हैं। यहाँ इस हॉस्पिटल की अगर मैं बात करूँ तो यहाँ कई उच्च योग्य डॉक्टर नरेंद्र मल्होत्रा, डॉक्टर जयदीप मल्होत्रा जो कि प्रोफेसर भी हैं, प्रख्यात डॉक्टर्स हैं जो कि बच्चों के लिए एक तरह से अभिभावक हैं और उनके निदान उपचार से ही मरीज वो बच्चे ठीक होते हैं। मैं रेमो हॉस्पिटल का पुनः सभी डॉक्टर्स, नेता, स्मृति का भावविभोर होकर स्वागत करता हूँ। मैं IMS, AMS, AOGS, IM सपोर्ट चैरिटेबल ट्रस्ट का भी आभार और स्वागत करता हूँ। मैं सभी मेडिकल स्टूडेंट्स, अभिभावकों का भी हृदय से स्वागत करता हूँ। आज की सेमिनार में जो हमारा फोकस है वो आप देख ही रहे हैं, हेल्दी चिल्ड्रन हेल्दी नेशन। अगर बच्चा स्वस्थ होगा तो ही हमारा राष्ट्र स्वस्थ होगा। उसके अंदर जो आज हमने लेक्चर्स रखे हैं, हेल्दी प्रेगनेंसी, नवजात स्क्रीनिंग, रेयर डिजीज, भारतीय परिप्रेक्ष्य उसका क्या है, पेरेंट सपोर्ट ग्रुप का क्या कार्य हो सकता है, जेनेटिक काउंसलर की हाई रिस्क प्रेगनेंसी के अंदर क्या भूमिका हो सकती है और फिजिशियन जेनेटिक के बारे में क्या समझते हैं, ये सबसे इम्पोर्टेंट है। प्रोफेसर नरेंद्र मल्होत्रा इसके बारे में आपको जानकारी देंगे। तो सभी विषयों पर हमारा फोकस रहेगा। मैं आप सभी से अनुरोध करता हूँ कि इस सेमिनार को आप पूरा अटेंड करें और स्वस्थ बच्चा स्वस्थ राष्ट्र की परिकल्पना को साकार करें। मुझे आशा ही नहीं, पूर्ण विश्वास है कि आज की इस सेमिनार न केवल हमारे उद्देश्य को पूरा करने में सहायक सिद्ध होगी, वरन हमारी परिकल्पना को आगे बढ़ाने में सहायक और ज्ञानवर्धक रहे। मेरी आप सभी से, विशेषकर सम्मानित डॉक्टरों से अपील है कि इस तरह की सीएमई राउंड टेबल डिस्कशन वेबिनार को आप अनवरत रूप से जारी रखें जब भी हमारा सहयोग आपको चाहिए होगा। अभी डॉक्टर साहब मुझे बता रहे थे कि 22 हॉस्पिटल है पूरे भारत में आप लोगों की, तो अगर 22 हॉस्पिटल में आपको जब भी हम लोगों की जरूरत होगी हम वहां पर जरूर आपका सहयोग करेंगे। उन्हें आप सभी लोगों का धन्यवाद, वंदन, अभिनंदन कि आपने हमें मौका दिया। आप सभी का मैं वापस से स्वागत करता हूँ। बहुत बहुत धन्यवाद।
Thank you, sir. Now I would like to Now I would like to welcome our President of AOGS family, Dr. Savita Tyagi ma'am. She is a leading gynecologist of Agra and owner of Ujala Cygnus. Welcome ma'am.
जैसे कि भी हम लोगों ने सुना कि जो एमईआरडी फाउंडेशन है ये मेटाबॉलिक में सहयोग कर रहा है और जैसा हम लोग अभी अनुभव नहीं कर पा रहे हैं और कई बार ऐसा होता है कि बच्चों को ये परेशानी होती है, काफ़ी लेट पता चलती है ये चीज़, जैसे डेफिशिएंसी। तो जरूरी है कि हम सब बच्चा पैदा होते वक्त ये टेस्ट करा दें जिससे तो बच्चे की होने वाली कोई भी परेशानी का हम पहले से संज्ञान भी ले लें और उसका हमें रहते हुए हम उसके पेरेंट्स को भी अवेयर करा दें कि बच्चे को क्या दिक्कत है। और इसी क्रम में आज हमारे बीच में काफ़ी अच्छे स्पीकर्स हैं, मैडम जजी मैडम हैं, नरेंद्र सर हैं, उसके बाद एक हमारे बीच में डॉक्टर स्वाति हैं। तो आज हम सब लोग इसके बारे में काफ़ी अच्छे से जानकारी देंगे और ये हम लोग सभी लोगों के लिए मुझे बड़ा विश्वास है कि आगे हमारे कार्यक्रम में काफ़ी कामगार सिद्ध होगी।
Thank you ma'am for such a good welcome. Thank you. To kick off this session now, I would like to invite Dr. Rajesh Gupta sir. He is professor in pediatric surgery in SN Medical College. He is a renowned pediatric surgeon. He has experience for the past. Now I would like to invite Dr. Savita Tyagi ma'am. She is a renowned and senior gynecologist. Dr. Anjali Gupta ma'am, please come. She is a renowned radiologist at Anjali Radio Diagnostic Center.
इसका लिंक ऊपर बढ़िया कौन सी कोड मैनेजर मैं आपको पूछता हूँ।
Now I will ask and request all our chairpersons to please welcome our first speaker for the evening, respected Professor Dr. Pratik Malhotra ma'am.
Good evening. It's my pleasure to invite Madam Professor Jati Malhotra to the dais. She is the Managing Director of Rainbow IVF Center and she is Vice President of the Indian Society of Aesthetic and Regenerative Gynecology. She is also a Chairperson of EGO Committee of Reproductive Medicine, Endocrinology and Infertility, and she is immediate past President of the South Asian Federation of Menopause Society and SPAD. And there are several awards and posts which she has held in the past. I would like to welcome Madam. to give her address.
Thank you so much and a very good evening to all of you. At the outset, I'd like to thank IEM and Merck for giving me this opportunity. It's really, really important for all of us to understand a lot goes on in the mother's womb before we are born, which leads to a lot of other issues which we are going to deal with. And I'm here just to make you a little more sensitized towards the whole issue. So this presentation is basically prepared for those who are actually motivated to care for the mothers, who have time to spend with their patients, and who also know that their few minutes well spent or invested are going to have a deep impact on somebody's life. Their small efforts can actually reduce the burden on the health infrastructure, which again is a huge amount in our own country. And of course, will help them achieve a much greater. My presentation is basically for all these people. I want to tell you a few things, a few facts. In our country, we have the cardiovascular or the non-communicable NCDs coming at almost a decade earlier than the Western counterparts. We are the diabetic capital of the world. Even if I just give you the figure of South Asia, we have about 88 million diabetics in only our region. And out of that 88 million, 77 million are in our country. 68% of the under 5 deaths in India are because of malnutrition, whether it is under or whether it is overnutrition. And if you are looking at preterm birth, India and China have the same population, the same amount of births happening, but in our country is that if we are even looking at any congenital malformations, preconception, in the periconception, and then in the neonatal screening, these are very, very important pillars for us to rule out. This is another very important area which we don't even think about. And what is that? Endocrine disruptors. Our everyday use products which we are using have a tremendous impact on a lot of things in our life. I'm just going to tell you. And a lot of times we feel that if somebody is exposed, at least of all the baby inside a mother's womb is not going to be exposed to it. If I tell you that today more than half of the babies are born with these EDCs or endocrine disruptors in their blood. So you can imagine when can they be exposed to the endocrine disruptors. It is right from intrauterine, perinatal, puberty, adult, it's through the lifetime or the life history which is there. And these are nothing but the day-to-day products which we use, the water which you drink, the air which you are actually breathing, the cosmetics which we use, the foods which we are eating, the colors which we are using. I mean, sky's the limit and there's no end to what these can have. So, the pesticides in the food. Now, what all these EDCs can do to us, if you understand, they are obesogens, where obesity, we are the obesity capital of the world. They are diabetogens, they are thyroid disruptors, they are neurodevelopmental disruptors, they are reproductive disruptors, and also fertility disruptors. These are just a few to name. I'm not even looking at carcinogenic and a lot of other things. Now, whenever a baby is exposed in the mother's womb, the next 2 generations are exposed. So it's not only the mother who is exposed, but the next 2 generations are exposed, and this is something which is transgenerational and can have a lot of effect on the future generations. So if we are really caring, then we will really look at optimizing these parameters much earlier than in late antenatal period, and that's something which is very, very important for us to understand. So that's where when we say there is an early origin of non-communicable diseases, these are a few of the reasons which are there. If you want to read a little more, there are many, many books which are available. I don't have much time to go into the details, but yes, fetal programming is real. And fetal programming is something which we should definitely be be looking into, because today we do understand that there is genetics at one end, there is an environmental determinism at the other end, and in between is the epigenetics. So if you are able to change your epigenetics or your lifestyle, current modification of your lifestyle and your habits, you will be able to change the genetics of the future 2 generations. And that is something which I really want to emphasize. If I ask you here, which one is of these mouse or mice which are there is the healthiest? And most of you will say the one with the golden brown coat and which is a little obese. And if I tell you that is the one who, with that mouse is more prone to diabetes, more prone to cancers and is obese, and that the color of the coat is because of the improper DNA methylation, then you will understand what I am really talking. So the healthiest one is the one which is on this side with the dark brown coat here. And this is all about methylation of the agouti gene. Now, DNA methylation, I think yesterday or day before yesterday, I was talking about fibroids and I was talking about DNA methylation as a contributor in development of the fibroids. Now, again, if you see DNA methylation has a link with a lot of human diseases like lupus is there, muscular dystrophies, diabetes, hypertension, obesity, cardiovascular diseases, schizophrenia, and many more. I mean, I can't really name each one. So, what I'm really going to emphasize here today is that genetics is the hardware, but the epigenetics, the lifestyle, the food, the exercise, and all those things are the software. So if you can actually change the software, then you will be able to change many things in the generations to come. Another very important aspect in mothers is the perinatal mental health, which we hardly think about. I think just now somebody was telling me that, a story about when a mother just found out that the baby was not normal, she committed suicide. Now, these are the things which actually need how to break the news, how to counsel her, how to tell her the gravity of the problem, so that we prevent what has actually happened. Now, and those are the soft skills which we are really not having, or maybe we are not concentrating on. We always blame it on the paucity of the time, but it's not always the paucity of the time, it's the paucity of the intent also. The moment we will understand the repercussions of our not counseling well, we'll start doing what we have to actually do. And mothers who are actually undergo depression or have a lot of domestic violence or are not treated well, it's not only that they are suffering. Their children and the personality disorders in their children are going to come out, and that is where you are seeing more and more of personality disorders in I would say not in our country, it's all over the world, because the domestic violence or a bad family environment is rampant all over the world and globally. Now, there are many direct contributors to maternal mortality and morbidity and even also pregnancy outcomes, which we all know. Undernutrition, overnutrition, obesity is there, hypertension, hyperglycemia. Because all these people who are having these problems, when they are going to have babies, their future generations will also be born with all these problems. So we must understand whether it is undernutrition or it is overnutrition. There is a definite fuel-mediated testogenicity which is there. Most of these children will be born with hyperinsulinemia, and insulin resistance is going to be there, and these are the ones who will be really prone to having all these non-communicable diseases later on in life. Us gynecologists especially, most of the times concentrate on the antenatal period. And if I tell you antenatal period is too late for everything, because by the time we are able to detect anything, if I tell you between day 17 to day 56, the heart begins to beat, and that's day 22 of conception. The neural tube closes by day 28. The palate fuses by day 56 just after conception. It's too late to prevent any implantation errors. It's too late to restore any allostasis. So we must concentrate on optimizing preconception health, which is very important. Because if we are able to optimize, because a lot of these obese patients are coming how many of us actually tell them that, please go back, do all these, reduce your weight, reduce your disease burden, and then maybe, go ahead. Because if you invest in the pre-conception period, the value is the maximum. And as we go into the implantation, first trimester, and you see here at later pregnancy, the value keeps on decreasing, and there's nothing much we can do later in pregnancy, whatever we will be able to achieve in the pre-conception period. So pre and peri-conceptual health is something which we should definitely be optimizing on. So if you see here, now there's a direct connection of what we are exposed to in the pre-pregnant, pregnant and adulthood, right from environment, lifestyle, genes, reproductive disorders, and the time of exposure has a direct impact on the disease and the disability which we are going to suffer in later life. So we can actually blame our parents that I am diabetic because of my mother or my father or my grandfather having diabetes, but what have I done to prevent it from happening to my children or my grandchildren is something which we need to really think on. So minus 12 weeks, that means 3 months before conception to plus 8 weeks is the only period or the peri-conceptual period where everything is happening. I'll just give you very short, small examples of how so many things which we think that we don't understand are actually understood, but we are not doing much about it. Now, peri-conceptual period actually influences a lot of organization as far as our DNA is concerned, our epigenome is concerned, the mitochondria, the metabolism, the placentation, the organ development, and also on the gametes which actually form the embryo and the fetus. Now, just one short example here if you will see. Now, this is something what dietary food inflammation and toxins does to our oocytes. So if you see here, if we have a lot of dietary fat, this is a normal oocyte with dietary fat droplets inside the oocyte. This is what happens with an increase in the lipid intake. Again, if you look at the sugars, how they are actually affecting the mitochondria. This is the mitochondria in the oocyte. Mitochondria are the energy providers. They are the basic things. Now, what happens to the mitochondria if we have more of lipids and sugars, which actually alter the mitochondrial activity? And similarly for micronutrients, it will have an impact on the DNA modification. Now, when these oocytes get actually fertilized, what will be the outcome of those embryos? We have to understand, because so many times people come for IVF to me and they ask me, why were the embryos bad quality? It's not written on the oocyte. I can't see these fat droplets or these mitochondria on a normal microscope which we normally look at, because this is all inside and this is what is impacting. Now, if I optimize earlier, then it is definitely going to have a better outcome. So this is what, it's a very beautiful picture. See, look at the mitochondria, it's all red here, which are there in the normal diet. Now, if you feed people on a high fat diet, look at the mitochondria in this oocyte. It's just one example I am giving you how they can really disrupt. Another important factor that we don't focus on is the male partner. When the woman is obese, comes with an obese man, we are only instructing her because we feel, oh, the men have to just give us sperm. But if I tell you that men have obesity or they have increased BMI, and when we do the pregnancy assessment, the pregnancy rates are very much decreased, and also there are miscarriages are much more common. So men also have a big role to play. Their obesity, their glucose tolerance test, they have a big role, and also the quality of the embryos is also not very good. Now, an impaired paternal obesity can actually have an impaired glucose tolerance test. So we must focus also on the male partner, which is very important. Now, this is a little bit of the history. Now, let us understand the consequences of all these. Now, if somebody suffers from hypertension, you can understand in pregnancy especially, she has a higher risk of cardiovascular disease later on in life. She has a higher incidence of cerebrovascular accidents and kidney disease later on in life. So, isn't it really important for us to make her understand all these in the preconception period. If somebody has gestational diabetes, and this is again we just learned a few days back only, then definitely there are increased chances of this patient developing a full-blown gestational diabetes in the times to come. And isn't it important for us to understand and then look after and do that aftercare which is really required? If somebody has a preterm baby, which is so common, sometimes an iatrogenic preterm births are also very much common. Now these babies are more likely to have cardiovascular disease. So where are we adding on to the burden of non-communicable diseases in our country? And we ourselves are also doing it. And hyperhomocysteine again is one of the other major contributors. So here you have a whole cycle, right from prenatal factors to perinatal factors to childhood factors to adult risk factors and then adult diseases, which are, there's a whole interconnection which is there. Now, how can we really modify? And I will really tell you that we obstetricians are the ones who are the only ones actually, who get almost 1 year with one patient. We get at least 9 or 10 interactions with the patient which nobody else gets. And we can really use this opportunity, and this is what we call as pregnancy as a window of opportunity, where you could actually teach this couple and the family a lot of things. And take this opportunity every time and they come, that this is one small thing which I have to tell them, based on their family history and their health, that can have a great impact on their future. And that's something which we are really looking forward, and I hope we all understand today, you all are the ambassadors for these messages, because only one high quality intervention which is related to maternal and child health, if we are able to achieve those objectives, the benefits are going to be unimaginable, and that's something which we should be looking at. Now, you may say, what am I really talking? This is something which everyone knows. But I would tell you that knowing is really not enough. We must apply it. Willing is not enough. Everybody is willing to do it, but a lot of people don't do it. We must do it, because when we are willing and when we do it, then only we will be able to achieve what we are really wanting to achieve. So don't lose any opportunity, how big or how small, to reach whatever we are really looking at. Here I would just take a moment and ask, who is a good doctor? Because a good doctor is the one who actually bridges the gap between the science and the society. A good doctor does not treat the disease. The good doctor treats the person. And that's something which is very, very important for us to observe, record, tabulate, communicate, and use all our 5 senses, which are very important to learn to hear. We don't hear. The patient is not even allowed to talk for 2 minutes in our OPDs. We are only with the prescription, and that's something which is not the right way. You should also learn from the past and research the present to predict the future, and this is exactly what I'm trying to tell. So, right from preconception, I'm not going to go into the details of what we all can do in the preconception, to the first trimester counseling, to the first trimester screening. There are many things which we can do here, to the integrated screening strategies which are there, which I think will be discussed a little later, to this universal screening by DIPSI, and also the neonatal screening, which I think is not really as acceptable as it should be, to prevent a lot of these diseases which can come in later in life. But what has really happened is that we, and many of us obstetricians, have actually lost either the focus or the motivation, for which we actually took this speciality, and we have a very important role to play. We are not robots. We cannot work like robots. We have to work with people who have trained ourselves for many, many years, and we are the ones who can be the game changers as far as the health of the women and the families who are connected with us. And we should be really focusing not on only short-term but on long-term health benefits, which are very important, and this is the approach which I would really like each one of us to focus on. So a very focused preconception care then a focused antenatal care, a very holistic and dignified healthcare provision. With birth preparedness, again, very, very important because the majority of the women are not really prepared for birth and complication ready, and that's where all the litigations come into place. And then a very integrated approach as far as the maternal and child health care is concerned. These are the ones which are very important. Now, I understood all this long time back. I tried many things. We made small groups, we made clubs for people to understand, but we could not reach out to many people. And that is where iMoms app was born. Now this app won the Pradhan Mantri's Atmanirbhar App Challenge. This app is on the Google Play Store. It's the best 10 apps on Google Play Store. We were also on the Shark Tanks. This app is based on Garh Sanskar, which is again an age-old understanding from our own country on how our ahar, vyavhar and sanskars can actually have an impact on the future generation, and plus it is based on fetal origin of adult diseases. So it's an amalgamation and integration of these two very big entities which actually help women right from preconception to pregnancy to parenting. So there are three aspects of it. We have Veer Sanskar, which is there for preconception care, and then we have this iMoms app, and then we have also a parenting app which actually prepares couples, not only pregnant women but couples for parenting and good pregnancy and holistic approach. So the components are preconception counseling, antenatal care, birth preparedness, diet and nutrition, cosmetic care, immunization, yoga, exercise, music and meditation, bonding with your doctor and the baby, and also postpartum care, and then parenting, which is all there. Now, why these are important? Because if we lose out on any one of these aspects, and especially it was born when the doctor-patient relationship was at its lowest. Now, how do you really build up the doctor-patient relationship? How do you really build up the interpersonal relationship? How I interact with my pediatrician, how I interact with my radiologist, how I interact with my anesthetist, and what those interactions can have an impact on the patient and the family and the children who are going to be born with us is something which we have to just sit down, close our eyes and try and understand. And then our practices are going to definitely change because we don't have time to think about all those things, and I urge you to think. Because I could not instill a lot of these things in everyone's mind was actually related to this whole branch, we took help of many people. We took help of spirituality because spirituality is again something which brings you closer. Science and spirituality have to go hand in hand. So Brahma Kumari Shivani is very, very close to me. She launched this project of Adbhut Matritva, which actually has all these ingredients. We had Shri inaugurating. We have really employed as many people as we could. We educated ANMs, we educated medical representatives, we educated the support staff. We basically started skill enhancement for a lot of support staff. There was a film made, if you have time, it's on YouTube. You can see this film actually won the award last year on the Lucknow Film Festival, which is called Adbhut Matritva. And it's a very interesting film which, with the day-to-day, small episodes, you'll understand how it can impact on many things which I have actually talked about. And what new we have added on the app is that we now have pregnancy coaches. If we don't have time, the patient can pay and have a nutritionist, a yoga instructor and a pregnancy coach with them, which will give them the desired information and take care of this pregnancy, and will also improve our quality of work because then I can concentrate a lot on many more patients while the counseling part can be taken up by all of them. Now, what are the outcomes if we practice all this what I have talked about? This is my last slide. First and the most important one is making motherhood a blissful experience. Pregnancy is not a disease. We treat it as a disease. Pregnancy is a very, very natural phenomenon, so we should not diseaseify it, which is very important. So never scare the patient. You are the nurturer, you are the Sarthi, as you are the Krishna of that pregnancy, so be a Krishna, which is important. Bonding of the mother and the father are very important, and bonding of the family is very important because the baby listens to about 5,000 words after 20 weeks of gestation. So the relationships of the baby are formed with people before he is born, he or she is born. So we have to understand that. So the family environment, not only focusing on the food and the medicines, all those things are also very important. Bonding of the couple with the doctor and the hospital, again very important. Patients most of the times come, they think, oh, this hospital is only extracting money. How is a hospital or a doctor going to give more than the money they pay us? These are the ways where we can do it. Allaying the fear of vaginal delivery. 90%, 100% cesarean section rate. Why? That's a question we have to ask ourselves. Sensitizing many important aspects of pregnancy and postpartum care. Prepare them for spacing, birth spacing during this period so that they do not have another child within 1 year. And this is the way we will be able to build up a healthy future generation. And this is one of the algorithms which you can take, I can put it on the WhatsApp group, which actually tells us about the antenatal care testing protocols, which starting from the preconception to the first trimester, second trimester, and third trimester, and also the newborn screening. And this whole program has been very well accepted by the government of India. Today, this Adbhut Matritva, Surakshit Matritva is based on Adbhut Matritva. Because this is the interaction which we had during my presidentship with our then health minister, which has actually been now transformed into Surakshit Matritva, and it's all over the country, and this is one thing which really makes me very, very proud of. So if mother and maternal and child nutrition and stressors can actually be optimized, the benefits which will actually accrue and will actually extend for generations to come. Which is why I say, let us work together to see this opportunity, which is very important. Whatever we learn should have an impact on the society at large. Thank you very much.
It was an excellent talk. As we all Ghanaian patients usually come to us and as for the treatment of infertility, so we should catch the patient at the same time. We should do the counseling or preconception, whether we should take the proper family history, and also if patient is suffering, taking any medicines, because all these things impact the pregnancy of that particular woman, and that is very much important. So we should do the proper counseling for when patient met us for the first time to our clinic. Then when she comes in first trimester, that is also very much important, because if many times we are not asking about the patient is on any drugs, and they themselves say, I am taking this drug, should I continue or not? And these are many times patients are. I come across many times, I even don't know the patient is on the anti-epileptic, and they themselves say, madam, should I take or not? Because we don't go for all these details, we have very less time, but we should give the proper time to counsel about the diet, exercise, what medicine she should avoid during the pregnancy, and these all things are very much important for all gynecologists. And if patient is having any hypertension or diabetes and he is in danger, so we should not be in hurry to deliver her. We should take as much time as we can, because many times babies, we are in fear of IUD deliver the babies prematurely, and we could have even a week or more to such babies what I think. So that was a very wonderful, and we many times we don't see the husband whether he is having diabetes or not. We just go for the semen analysis, and if it is okay, then we don't care whether what is the BMI, whether he is having any disease. Today I learned we should also look into the husband's problem also. was really very wonderful. If anyone wants any question, they come.
I would like to have just one comment, ma'am. It was a eye-opener and a very sort of enlightening lecture for me as a surgeon. Being a teacher in medical college, and I see this problem is more prevalent amongst medicals. I see female residents stressed out, running here and there, not having their breakfast or lunch in time, and some of them obviously they do get pregnant, married and pregnant during their residency, and this puts a lot of stress on them and on the baby also. So I would like to have just one comment, your experience about it.
It's not your experience, it has been my experience in my pregnancy also. So the whole program actually was born out of that, and I was the president of our organization. My theme was quality, ethics and dignity for doctors. And we ourselves, doctors who are teachers in the medical college, get this. That this is something, these girls are studying for 10 years, they are already married late, and I mean I can go on and on. I can tell you now today, between 28 years and 33 years, if I do the AMH, which tells us about the ovarian reserve of these young girls, which we call as young girls, by the time we finish our MS, we are 28 years old, is so low that if they don't plan their pregnancies in the next few years, it is something which is going to be a big problem for the whole country. And we already have our total fertility rate, because see, we don't look at the larger picture. And most of us, when I was pregnant, I did not have the courage to tell my boss, who was very fond of me, till 28 weeks. She could not guess I was pregnant. When I had to take leave for an ultrasound the day when she found out, and because what used to happen was that the moment you found out that this particular girl is pregnant, she was not allowed in the OT, she was humiliated. She would say, okay, वहाँ खड़े हो जाओ जाके कोने में, तुम अभी असिस्ट करोगी तो गिर जाओगी और तुम ठीक से कर नहीं पाओगी, and all those things used to happen. So we never had the courage to even tell. Now who has to be sensitive to all this? Then that's something, guys. This was the pledge which I asked all the medical college professors who were coming, who were part of our organization, that we need to be sensitive about all this. Because this is part and parcel of a woman's system. Men cannot be pregnant. So if a woman has to be pregnant, she has to be supported in every possible way. And I think that mindset change is very important.
From the audience.
Thank you so much. Developing soft skills and patient communication is very important. I'm a radiologist, I do scans, patients are with me for let's say 15-20 minutes. My mouth doesn't stop speaking, because then you have to understand what she's going through, and that the talking gives you a lot of insight into what she is actually experiencing. So kudos to you all, you ma'am, such a wonderful initiative, and I was really not aware of the epigenetics part of preconception. And ma'am, I am associated with Samrakshan, which is an IRIA initiative, and we are into sensitizing our radiologist colleagues for doing good ultrasound reporting and in all support to the gynecologists. So we would like, ma'am, on behalf of Samrakshan, I would like to invite you to give some sort of a preconceptional lecture.
Anytime, most welcome. And the other part of the initiative which I took was quality, ethics and dignity for doctors, health empowerment and respect for women. Now, most of the time when you see, and I am sure each one of us, we are not actually sensitive to how the patient lies, whether she is covered properly, you know, how we are talking. We are only talking to patients as a particular age. अरे वो उसको placenta previa को बुला देना, अरे फलाने को बुला देना. We are not sensitive to them, and that is something which again, you know, their trust in us is built up by the small acts which we do. And if those small acts which we call as soft skills are good, then you don't even have to talk as much, because they will in themselves start talking to you and telling you, a lot of things. We need to be good listeners. I get a lot of patients who come and they say, doctor, you doctors don't listen to us. Our interaction with them is only for 2 or 3 minutes, and in that only we are telling them something, we are not listening to them. So those are the other small efforts which we need to make. Thank you.
Thank you. Now I would like to invite Dr. Swati Dwivedi to give a talk on newborn screening, need of the hour. Dr. Swati Dwivedi is a pediatrician. Currently, she is Joint Secretary IIT Agra, and she is a Women's League Coordinator of IIM Agra. She has keen interest in critical care medicine, preventive medicine, and vaccination, and she conducts good touch, bad touch workshops, and also associated with various health awareness programs.
Thank you, sir. Good evening, everyone. I hope everybody is doing great today. So, as we talk about newborn screening, so why we have to discuss newborn screening? Newborn screening is totally a preventive medicine aspect. And as we know, West and as well as our country is moving towards preventive medicine, which focuses on preventing the disease. And if it all happens that the disease is occurring, then how to ameliorate the disease course and prevent morbidity, mortality, and disability related to the diseases. So what is newborn screening? Newborn screening is a public health program where neonates are screened just after birth for diseases which are not present at birth, which mostly appear later in their life but can be prevented by timely screening. So why to screen? Because these diseases are potentially fatal and debilitating and manifest later in the life or have high prevalence, and timely screening is the only way to cure or treat the disease. Why newborn screening is important in Asian Pacific countries like ours? Because we have high birth cohort and we target same health status for our children as that of the developed nations. And early identification, timely intervention is the only way to reduce morbidity, mortality, and disability. Now, the principles of newborn screening. In 1968, Wilson and Jupiter proposed the following criteria for the newborn screening. The condition should have an important health problem and should have high frequency. The test should be acceptable to the population. The test should be reliable and simple. Disease does not manifest at birth on routine examination, and treatment will prevent mortality and morbidity. Delay in diagnosis will cause irreversible damage like seizures, end organ failure, and screening is cost effective. So the minimum criteria for a disease to be included in newborn screening are that the screening can be done at 24 to 48 hours after birth, have a test specific and sensitive for the condition, early detection, timely intervention, and effective treatment are offered proven benefit. So coming to screening in Indian scenario, we can classify it into three major classes. First is hearing screening, then critical congenital cardiac disease screening, and third is dry blood spot for metabolic, congenital, and hormonal disorders. So first we will take hearing. In India, almost 1 in every 300 live births, there is a hearing defect. So what are the screening tools we have? First we have evoked otoacoustic emissions, and then there are also known as auditory brainstem responses. The results are shown as pass or error. So what do you do if there is a we do first screening and there is some defect in the hearing? Then we will repeat the screening after 4 weeks or at the time of first immunization. Then again, if there is a screening defect in the hearing, we will go for the third screening at the time of 3 to 6 months of age. And by the time the baby is 6 months of age, we will go for auditory rehabilitation. It is very important that by the 6 months of age, the auditory rehabilitation has been done. When to consider further hearing assessments? If there is a family history of permanent childhood hearing loss in a first degree relatives, there are dysmorphic features, and very important, if there is a history of in utero infection like toxoplasma, CMV, syphilis, herpes, measles, rubella, and varicella. Now, second aspect, critical congenital heart defects. We all have this oximeter in our OTs, clinics, and hospitals.
So very importantly, every child should undergo measurement of oxygen saturation after 4 hours. But do not take the saturation at the time of birth, because we are not targeting 95% saturation at the time of birth. The usual saturation at the time of birth is around 65 at 1 minute of life is 65 to 70%, and by 5 minutes of life it is 80 to 85%. So once the baby is 4 hours of life, you can go for the saturation, and the saturation is measured pre-ductal and post-ductal. For pre-ductal you can go for upper right limb, and post-ductal right lower limb. And if the screen is positive, then we can further go for echo and ECG. So in pulse oximetry, if the saturation of less than 95% in either of pre-ductal or post-ductal circulation is noticed, or the difference between the pre-ductal and post-ductal oxygen saturation is more than 2%, then these baby needs further evaluation. When to consider cardiology referral echo irrespective of the screening results? When we have a syndromic baby, when the US ultrasound finding the prenatal time such as some cardiac defect, if there is a cyanosis or murmur at the time of birth, and very importantly, baby born to diabetic mother. Third part of the screening, dried blood spot screening. It is a very simple method where samples are collected by the heel stick. Initially it was a disease-specific test, but now with the tender mass spectrometry, we are able to do multiple metabolic disorders at a time. So the basic testing methods are ELISA, isolated focusing, high performance liquid chromatography, calorimetric assay, tender mass spectrometry, and DNA testing. In this process, or whether if the patient is at home or hospital, the lab person will come, collect the sample, send the sample to the laboratory, and once the results are there, then they will be sent to the primary physician. The factors that can affect newborn screening results in these strict methods are age of collection. By age of collection, we will discuss later on. Prematurity, medication and diet, maternal conditions, collection method, ambient temperature and humidity, and time in the transit to the lab. So this is a very exhaustive list of conditions which can be screened like cystic fibrosis, hemoglobinopathy, congenital adrenal hyperplasia, hypothyroidism, thalassemia. But we will discuss few conditions which are commonly screened. The number one is the most important one: congenital hypothyroidism, G6PD deficiency, congenital adrenal hyperplasia, phenylketonuria, galactosemia, alternate acidemias, maple serum urine disease, and homocystinuria, also cystic fibrosis. So this is a very typical way of congenital hyperthyroidism: hypotonic, sluggish. You can see umbilical hernia. There will be persistent jaundice, protruding tongue. So if there is a baby, you can easily identify a baby with congenital hypothyroidism. So why it is so important? I have taken this case importantly because it is one of the most commonest cause, treatable commonest cause of mental retardation with quite a high prevalence in India. The prevalence of congenital hypothyroidism in India is 1 every 1,000 live births, which is quite higher than the other countries, and it is more prevalent in preterm babies. And falls also result to quarter sampling. So every baby should be screened after 72 hours of life. What is the cutoff value of TSH? For primary TSH, by Heath method of for TSH, the screening TSH should be 20 milli international units per liter, and then should be considered positive. So this is a flow chart, in not going into detail, but a few things that if we are taking the Heath method of cord blood and TSH is less than 20, we have not to worry about anything. But in case of TSH is more than 20, and if TSH is more than 40, then you have to immediately start the thyroxine. You do not have to wait, and have to send venous blood sample after 72 hours. And if the TSH is 20 to 40, you do not need to start thyroxine, but you have to send venous sample after 72 hours of birth. Now coming to cord blood versus heel prick method. So heel prick method is the preferred choice because at the time of birth we all know there is TSH surge. So we have to wait for the TSH surge to. So the preferred method is heel prick method, but if the baby is being discharged earlier, as we seen in the newborn normal vaginal delivery, then we can go for cord blood sampling. So what are the benefits of newborn screening? We can early identify the disease, then go for early intervention, reduce mortality, morbidity, and family planning, like in the disease like thalassemia. Risks associated with NBS are parental anxiety because of false positive results, missed cases because of false results, unanticipated outcome, and labeling for benign condition. Now, timing to perform NBS. In Western countries, the usual timing is 24 to 48 hours. But in our country, we have gone for the timing as 72 hours of life to 70 days of life. And 72 hours of life, especially because of congenital hypothyroidism. So in our country, we go for a newborn screening after 72 hours of life. So what is the role of obstetrician in a newborn screening? Obstetrician should have resources about newborn screening available, like which labs are doing newborn screening, what are the panels available, and they should try to incorporate the information about newborn screening in the prenatal and antenatal care. Role of a pediatrician in newborn screening, they have a very proactive role. Once they have the baby, they have to go immediately for these tests if required. So the take-home message is, make newborn screening a part of day-to-day practice in both obstetrics and pediatric OPD. Screen ideally after 72 hours of birth. And once the diagnosis is confirmed, go for the clinical intervention as soon as possible. I have a baby recently and 6 months of life, and she was having repeated episodes of liver failure. When she came to me, her bilirubin was 8 and she was having diarrhea, so I put her on lactose-free diet. And on second day, her bilirubin came down to 3. But then her parents thought that he गाय का दूध पिलाते हैं. They put again her on cow's milk, and next day the bilirubin was 11. They got very curious कि आप क्या कर रहे हो? And then that day I noticed cataract in her eyes. And we sent her to Jaipur, and that was a case of galactosemia, and it was diagnosed at 6 months of age, very late. So this is very important. Even with hyperthyroidism, it is very important. This is in our region. We are a major hyperthyroidic belt. So in our practice, what I am doing, we send TSH because we do bilirubin. After 72 hours of life, we should send TSH. At least G6 in every baby. If you have a history of thalassemia in the family or any hemoglobinopathy, you can go for those tests also. So be aware, be curious, and have a complete history. And don't hesitate to go for these tests. Thank you.
Very nice lecture. Although we are not doing for the routine TSS test in all babies, but according to you, we should do along with the bilirubin, we should attend this TSH also.
And there is a medical case also in India where the TSH was not done, and later
but we are doing the routinely antenatal patients TSS. And if patient is not hypothyroid, then we are not sending. We should be sent on all patients.
All patients. Because it is very cheap test, very easily available. We can go for it at least. Similarly,
but our pediatrician never advises us to go for this TSS test.
I think after this lecture, all the pediatricians are present here at times.
Pediatric surgeon.
Yes. Even the newborn screening plays a very important role in family planning. Like if there is a baby thalassemic, so how to go for the further pregnancy? That's a very important question patient will ask. So you have to go the DNA testing of parents, and then you will decide what to do further.
I get a lot of infants basically with problem of constipation, and I always used to look for surgical causes, being a surgeon. But at one stage, I realized this thing, hypothyroidism could be one of the causes. In a case which could be hypothyroid, I was trying to look for surgical causes in those.
Sir, the problem with disease is the metabolic disease. Once the baby present, there are end organ damage, liver failure, renal failure, baby is having seizures. You don't have much to do by that time. So newborn screening should be a part of our day-to-day practice.
Thank you, Dr. Swati.
ऐसे प्रोग्राम ये टेस्ट नहीं प्रोग्राम के रूप में ऐसा आपने डेटा दिया सीएच का तो बहुत ज़्यादा कितना ही है 1000 अगर 27,000 बच्चे अगर बाउंड्री का आते हैं 27,000 बच्चे अगर हम उनका 4 के एप्रोच नहीं करते 40% को अपना अचीव करो तो हम तभी सक्सेस कर पाएंगे जब तक हम उसको प्रोग्राम में। दूसरा ये टीम वर्क, हम ये नहीं कह सकते कि ये चाइल्ड डॉक्टर आ गए हैं आपके प्रोग्राम में अगर वो शामिल तो निश्चित ही हम उसको करेंगे।
तो एक ये पॉइंट जो था कि जब आप बच्चे का सीरम हेमोग्लोबिन भेजते हो, एवरी पेरेंट इज अवेयर अबाउट कि जन्म में जॉन्डिस होता है, तो उस टाइम आप कुछ टेस्ट करा सकते हो। ये जब पेशेंट आपके कांटेक्ट में होता है सबसे ज्यादा सुनता है आपकी वंस दे गेट डिस्चार्ज, तो आपने सुनना बंद कर देगा, तो आप उस टाइम का फायदा उठाएं।
सबसे जानते हैं कि जब आप एक सर्जरी करते हैं तो आप उनसे बिना पूछे एलिमिनेट करते हैं, ये तो करना ही करना है तो न्यूरोस्क्रीनिंग भी ऐसे खबरों का नाम हर सिंपल सीएच तो उसमें विजिबल ट्रीटमेंट
इसका मेजर पार्ट ये कि ह्यूमन स्क्रीनिंग का जो पैनल है वो एरिया वाइज है, बिकॉज सर्टेन डिजीज आर मोर प्रेवलेंट इन सर्टेन एरियाज, तो एरिया वाइज पैनल बना दिया जाए एंड देन द फैमिली हिस्ट्री, इफ देयर इज अ पर्टिकुलर डिजीज इन द फैमिली पर्सन रिलेटेड।
I think we are, Dr. Swati, we are running quite behind the schedule, so thanks a lot, and I would like to invite Mr. Vikas Bhatia, MERE India Foundation, for his talk.
Before Mr. Vikas says something, I will welcome our sir, Dr. G.V. Sharma, and we ask him to please join us.
धन्यवाद आपका। सबसे पहले मैं ऑर्गेनाइजर्स का धन्यवाद करना चाहता हूँ, विशेषकर सभी सम्मानित डॉक्टर्स का, मीटा, स्मृति, रेम्बो हॉस्पिटल, IM सपोर्ट चैरिटेबल ट्रस्ट को। विशेष धन्यवाद रेम्बो हॉस्पिटल के प्रोफेसर डॉक्टर नरेंद्र मल्होत्रा का। आपसे मेरा इंट्रैक्शन 6 साल पहले पटना एयरपोर्ट पे हुआ था। आपका एक लेक्चर था और मैं एक पैनल डिस्कशन में था, और हम पटना एयरपोर्ट पे मिले थे 10 मिनट के लिए कॉफी में बात हुई थी, और सेम मैंने जैसे डॉक्टर साहब को बोला कि ह्यूमन स्क्रीनिंग क्यों जरूरी है, मेरा वही डिस्कशन आपसे हुआ था। जैसा कि आप सब जानते हैं कि आज की CME हेल्दी चिल्ड्रन हेल्दी नेशन को लेकर है, जिसमें आप बेहतरीन व्याख्यान प्रोफेसर डॉक्टर जयदीप मल्होत्रा का व डॉक्टर वी स्वाति जी का सुन चुके हैं। मैं इस कड़ी में आपसे रेयर डिजीज, इसका भारतीय संदर्भ में क्या आजकल स्टेटस है, उसके बारे में बात करना चाहूँगा। उससे पहले मैं अपनी ऑर्गेनाइजेशन का आपको परिचय देना चाहूँगा। मैं विकास भाटिया मर्ड इंडिया फाउंडेशन, जो कि बेसिक रूप से मेटाबॉलिक एरर एवं रेयर डिजीज ऑर्गेनाइजेशन स्टैंड करता है, उसका फाउंडर हूँ। हम लोग अपने ग्रुप में 400 से ज़्यादा पेरेंट हैं, और हमारा जो मुख्य कार्य है वो है इनबॉर्न एरर ऑफ मेटाबॉलिज्म की अवेयरनेस, न्यूबॉर्न स्क्रीनिंग जो ट्रीटेबल डिसऑर्डर्स के लिए होनी चाहिए उसके कैंपेन, और पेरेंट्स को इंफॉर्मेटिव सपोर्ट देना है। पिछले 13 वर्ष हो गए इस ग्रुप को काम करते हुए। हमने 250 से ज़्यादा इसी तरह की CME ऑर्गेनाइज करी है या अटेंड करी है, और 12,000 से ज़्यादा पेरेंट्स को हम लोग इंफॉर्मेटिव सपोर्ट प्रदान कर चुके हैं। हो सकता है कि आप मेरे विचारों या तर्कों से सहमत नहीं हो, लेकिन मैं चाहूँगा कि आप उसे ध्यान रखो। अगर हम रेयर डिजीज की बात करें, क्योंकि आजकल रेयर डिजीज एक ऐसा सब्जेक्ट हो गया है कि जैसे ये शुगर का टेस्ट है कि मिस्टर भाटिया की शुगर 250 है तो उनको क्या दवा बताएंगे, बहुत ही इंपॉर्टेंट सब्जेक्ट है, सेंसिटिव सब्जेक्ट है। अगर हम उसको परिभाषित करें तो उसके कारणों पर जाए तो अधिकतर ये जीन, क्रोमोसोम या DNA में पैदा हुई असमानता के कारण होने वाली डिजीज है, जो कई बार या ज्यादातर इनहेरिटेड होती है। आबादी में कभी कभार पाए जाने वाली डिजीज रेयर डिजीज कह सकते हैं। रोग से पीड़ित लोगों की संख्या के आधार पर आप इसे रेयर डिजीज कह सकते हैं। कि कितना इसका प्रेवलेंस है, कितनी इसकी व्यापकता है, उसके आधार पर आप बोल सकते हैं कि क्या रेयर डिजीज है। WHO ने भी ये बता रखा है कि 10,000 पर अगर 10 से कम बच्चे आपको 10 से कम लोग मिलते हैं तो वो रेयर डिजीज की श्रेणी में आती है। इंडिया की अपनी कोई यूनिवर्सल डेफिनेशन नहीं है, लेकिन हम अगर WHO की माने तो इसी परिभाषा को साकार कर सकते हैं कि 1,000 पर एक बच्चा पाया जाए या 1,000 पर एक जगह पाया जाए या 2,000 पर एक जगह पाया जाए तो वो रेयर डिजीज है। तो अगर हम इसके प्रेवलेंस पर बात करें तो 7000 से ज्यादा रेयर डिजीज है, 80% जेनेटिक कारणों से होते हैं। सबसे इंपॉर्टेंट बात है कि 80% से ज्यादा जेनेटिक कारणों से होती है और सिर्फ 350 से ज्यादा डिजीज डायग्नोस्ड है और उनका ट्रीटमेंट हमारे भारतवर्ष में उपलब्ध है और सिर्फ 500 से ज्यादा ड्रग ऐसी हैं जो हम रेयर डिजीज के बच्चों को या एडल्ट्स को दे सकते हैं। और सबसे इसमें मैं वेदना के साथ आपको बताना चाहूंगा कि 7 से 8 साल लग जाते हैं हमारे भारत में इसे डायग्नोज होने में। हमारे देश में आप सभी लोग जानते हैं कि 24 मिलियन बच्चे यानी कि तकरीबन 2.5 करोड़ बच्चे हर साल जन्म लेते हैं। इसमें अगर हम आंकड़ों पर जाए तो हर 100 में से 6 बच्चा बर्थ डिफेक्ट लेकर जन्म होता है, उसमें कई रेयर डिजीज भी शामिल हैं। मैं ऐसा मानता हूं या जितनी मैंने स्टडी करी है 72% बच्चे इन 100 में से 6 अगर बच्चों की बात यानी कि 4 बच्चे रेयर डिजीज लेकर, क्योंकि 50% से ज्यादा रेयर डिजीज बच्चों को अफेक्ट करती है, 30% से ज्यादा ये नवजात को यानी कि 30 दिन से कम आयु में ये बच्चों को अफेक्ट करती है। अब हमारी IMR जो है वो 30 के आसपास हो चुकी है। आप सभी लोग जानते हैं, जितना मैं यूपी के बारे में जानता हूँ शायद 34 यहाँ की IMR है। तो अब हमें जब हमने कुपोषण, डॉक्टर ने भी मेलान्यूट्रिशन की बात करी, इन्फेक्शन पर भी काबू पा लिया है, सेप्टिक बच्चों पर भी काबू पा लिया है, तो अब हमें सोचना चाहिए कि अब जो बच्चे मृत्यु को प्राप्त हो रहे हैं, ग्रसित हो रहे हैं, तो मैं एक आंकड़ा पर आपको कहना चाहूंगा। आज भी हमारे देश के अंदर 6 लाख न्यूनेटल डेथ होती है, 8 लाख बच्चे अपना 1 साल नहीं देख पाते हैं और 10 लाख से ज्यादा बच्चे अपना 5वां जन्मदिन नहीं मनाते। इसमें कई लाख बच्चे रेयर डिजीज से ग्रसित होते हैं। तो अगर हम इसे एक पिलर की तरह बात करें तो अवेयरनेस, डायग्नोस, ट्रीटमेंट और प्रिवेंशन, इन पर रेयर डिजीज का एक बिल्डिंग खड़ी होती है। तो अगर हम अवेयरनेस की बात करें तो आप सभी लोग जानते हैं कि हम लोग फरवरी का लास्ट दिन 29 फरवरी लीप ईयर में या 28 फरवरी को रेयर डिजीज डे मार्क करते हैं और पूरे भारतवर्ष में बहुत लोग रेयर डिजीज के अवेयरनेस के लिए काम कर रहे हैं। सितंबर का पूरा महीना न्यूबॉर्न स्क्रीनिंग मंथ के रूप में विख्यात है। 21 नवंबर को हम लोग IM डे, इनबॉर्न एरर ऑफ मेटाबॉलिज्म डे मनाते हैं। 25 अप्रैल को हम DNA डे मनाते हैं। ये सभी अवेयरनेस के लिए हैं। इसी तरह की CME करते हैं, राउंड टेबल डिस्कशन करते हैं, डॉक्टर लोग अपने आप डिस्कशन करते हैं, तो ये सब इसके अवेयरनेस के लिए है। और 50 से ज्यादा, आप सब लोग सुनकर हैरान होंगे कि पिछले 10 वर्षों में 50 से ज्यादा सपोर्ट ग्रुप पूरे भारतवर्ष में इन रेयर डिजीज की अवेयरनेस के लिए काम कर रहे हैं, जिसमें 2 सपोर्ट ग्रुप, मैं खुद मार इंडिया फाउंडेशन से मैं और मेरी वाइफ और IM चैरिटेबल ट्रस्ट से अतुल जी और सारिका मोदी जी आए हुए, हम 2 ग्रुप भी काम कर रहे हैं। अगर हम डायग्नोस की बात करें तो डॉक्टर साहब ने अभी बात करी प्रीनेटल डायग्नोस की, PGD की, न्यूबॉर्न स्क्रीनिंग, NGS, बहुत तरीकों से हम बच्चों को उनके परिवारों की मदद कर सकते हैं। अगर हम ट्रीटमेंट की बात करें तो ड्रग की उपलब्धता, वैसे मैं आपको बता चुका हूँ कि सिर्फ 500 ड्रग है इन 7000 बीमारियों के लिए या जो डायग्नोस हो चुकी है 350 बीमारियों के लिए। लेकिन अभी गवर्नमेंट ऑफ इंडिया बहुत पुरजोर काम कर रही है रेयर डिजीज बच्चों की ड्रग की उपलब्धता को करने के लिए। मैं आपको 4 दिन पहले का उदाहरण दे सकता हूँ। अभी जयपुर की डॉक्टर स्वाति ने बात करी, तो अभी एक SMA के बच्चे को जिसका नाम अज्ञात था, उसको SMA का जो 16 करोड़ रुपए का इंजेक्शन लगता है वो उसे लग चुका है। वो बच्चा बिल्कुल स्वस्थ है, इस वक्त अंडर मेडिकल केयर है। उसमें से 8 लाख जो 8 करोड़ रुपए थे वो उसे माफ कर दिए गए कंपनी की तरफ से और शायद 6 या 7 करोड़ उसने क्राउड फंडिंग से मदद से उसने साबित किया, बच्चे को वो ट्रीटमेंट मिल गया। ERT, एंजाइम रिप्लेसमेंट थेरेपी, आप सब लोग जानते हैं कि कई लाइसोमल स्टोरेज डिजीज के अंदर ERT भी उपलब्ध है। डाइट मैनेजमेंट, कई इनबॉर्न एरर ऑफ मेटाबॉलिज्म जो डाइट से मैनेज हो सकते हैं, जिसके लिए जितनी डाइट होती है, तो फूड सेफ्टी वालों ने डाइट फॉर लाइफ करके प्रोग्राम चालू कर रखा है। और जो डाइट पहले आज से 5 साल पहले 10,000 रुपए में 8,000 रुपए में एक दिन आता था, आज वो दिन बाहर वाले भी 5,000 रुपए में दे रहे हैं और 2 इंडियन कंपनी भी डाइट बना रही है जो 1200 से 1400 रुपए में आपको आसानी से मिल जाती है। जो बात मैं आपसे करना चाहूंगा, आपसे अपील करना चाहूंगा प्रिवेंशन की, सबसे इंपॉर्टेंट जेनेटिक काउंसलिंग है जो हमारे देश में इसका बहुत बड़ा अभाव है, जो जरूर होनी चाहिए फैमिलीज की। गाइडेंस का इन्वॉल्वमेंट बहुत ज्यादा जरूरी है क्योंकि 9 महीना जच्चा और बच्चा आपके संरक्षण में रहते हैं। आप हमेशा उनकी सेहत के लिए सोचते हैं, लेकिन जो बच्चा 9 महीने जिस जच्चा और बच्चा के लिए आप इतने तत्पर रहते हैं, क्यों नहीं आप इससे न्यूमन स्क्रीनिंग के लिए इन्फॉर्म करते हैं? क्यों नहीं अगर वो पहले ही टर्म पे आप पर आता है और हाई रिस्क प्रेगनेंसी है तो आप उसका प्रीनेटल डायग्नोज करवाने की कोशिश करते हैं? मेरी आपसे अपील है कि आप जरूर इन्वॉल्व होइए और चाइल्ड केयर डॉक्टर के साथ मिलकर इन फैमिलीज की भी हेल्प करें। रेयर डिजीज रजिस्ट्री हमको चालू करनी चाहिए जिससे भी हम पता कर सकें कि एक्चुअल में कितने रेयर डिजीज के बच्चे आ रहे हैं। प्रीनेटल डायग्नोज और पीजीडी और न्यूमन स्क्रीनिंग से हम हजारों फैमिली की हेल्प कर सकते हैं। बहुत कम कार्य हो रहा है। मुझे बताते हुए थोड़ी सी वेदना है कि केवल 3% बच्चे ही हमारे भारतवर्ष में न्यूमन स्क्रीनिंग की प्रक्रिया से गुजरते हैं। अभी भी 97% बच्चों को न्यूमन स्क्रीनिंग का लाभ नहीं मिल रहा है, जबकि मैं अभी आपको बता चुका हूँ कि सिर्फ थायराइड से 27,000 बच्चे आते हैं, G6PD से 1 लाख से ज्यादा बच्चे हमारे भारतवर्ष में आते हैं, जिसमें आपको कुछ भी नहीं करना है, सिर्फ पेरेंट्स को इन्फॉर्म करना है कि पर्टिकुलर मेडिसिन या पर्टिकुलर डाइट इस बच्चे को नहीं देनी है, क्योंकि वो बच्चा कभी ना कभी आपके पास जॉन्डिस लेकर आएगा, पेन लिखा हुआ आएगा। अगर हम गैलेक्टोसीमिया की बात करें तो जो आंकड़ा मेरे पास है 30,000 से एक बच्चा गैलेक्टोसीमिया लेकर आता है। ऑर्गेनिक एसिडीमिया के बहुत ज्यादा प्रॉब्लम है, 5,000 पर एक बच्चा आता है। तो आपको न्यूमन स्क्रीनिंग के लिए भी पेरेंट्स को इन्फॉर्म करना है, तो करवानी है। NNF, IAP, पोस्टी एक टीम वर्क लेकर अगर काम करें तो निश्चित ही हम इन फैमिलीज और बच्चों के साथ न्याय कर सकते हैं। अगर मैं गवर्नमेंट इनिशिएटिव की बात करूं तो गवर्नमेंट ऑफ इंडिया ने 2021 के अंदर रेयर डिजीज पॉलिसी को लॉन्च किया है और 12 सेंटर ऑफ एक्सीलेंस इस विषय में काम कर रहे हैं, अच्छे से काम कर रहे हैं और गवर्नमेंट ऑफ इंडिया उन्हें 50 लाख रुपए तक का बेनिफिट दे रही है आप ट्रीटमेंट, लेकिन उसके लिए हमें टीम वर्क करने की जरूरत है। और जो रेयर डिजीज पॉलिसी में हम लोग कोशिश कर रहे हैं, मुझे बताते हुए बेहद खुशी है कि मैं भी उस स्टेक होल्डर कमेटी में शामिल था। 2017 के अंदर हमें शामिल किया गया और हमारे ही प्रयासों के बाद में हमने 3 खंडों में इसे बांटा कि कौन सी इजी ट्रीटेबल है, कौन सी टाइट से मैनेजमेंट है, इसमें हम क्राउड फंडिंग करा सकते हैं। हम कोशिश कर रहे हैं कि वो और उसका सरलीकरण हो। अवेयरनेस की मैंने आपको बात करी, जो मैं बात आपको कहना भूल गया, बॉलीवुड भी बहुत तत्पर है इस अवेयरनेस को लेकर। आपने कई मूवीज का नाम सुना होगा, 5 मूवीज जिसमें अमिताभ बिग भी और छोटे भी दोनों थे, उसमें उनको शायद प्रोजेरिया करके डिजीज थी, हिचकी में रानी मुखर्जी उसको भी एक डिजीज थी, उस डिजीज को लेकर हुआ था। तारे जमीन पर आप सब लोग जानते हैं वो किस डिजीज पर थी। बर्फी के अंदर जो रणबीर कपूर था उसको ऑटिज्म था। मेरा इंग्लिश का प्रोनाउंसिएशन बहुत अच्छा नहीं है, मैं हो सकता है कुछ शब्द गलत बोल रहा हूँ आपसे। बहुत अच्छी पिक्चर आई थी द स्काई इज द पिंक, वो स्किन डिजीज को लेकर थी। और मैं आप सबसे अपील करूंगा और मेंबर ऑफ डॉक्टर नरेंद्र मल्होत्रा से अपील करूंगा कि आप अपने पूरे स्टाफ को, अभी जो लेटेस्ट मूवी आई है श्रीकांत, जिसमें विजुअल एम्पायर उसको दिखाया गया, बहुत कमाल का उसमें अभिनय किया। मैं चाहूंगा कि हॉस्पिटल में कुछ दिखाई जाए तो हम इन डिजीज को देखकर देख सकते हैं कि उनको क्या जरूरतें हैं उनकी। अगर हम नीड की बात करें, हमें इन रेयर डिजीज बच्चों की या एडल्ट्स में क्या नीड है, तो सबसे पहला काम जेनेटिक इंश्योरेंस। हमारे पास में जेनेटिक इंश्योरेंस नहीं है। मैं उनकी बात बिल्कुल नहीं करूंगा कि जो आ चुके हैं बच्चे, मैं उस प्रिंसिपल एक्ट का टाइम बात करूंगा कि कंपनियों को बाउंड किया गया है ARD को इंश्योरेंस। अगर कोई बच्चा रेयर डिजीज लेकर या डिजीज लेकर आता है तो उसे इंश्योरेंस प्रदान किया जाए। अवेयरनेस हमें बहुत स्तर पर बढ़ानी है। हमें मेडिकल स्टूडेंट्स पे, नर्सेस पे, हमें इन पर अवेयरनेस पहुंचानी है। हमें सही डायग्नोस्टिक ट्रीटमेंट की जरूरत है। हमें ड्रग डेवलपमेंट की जरूरत है। जो इंजेक्शन 16 करोड़ रुपए का वहां बनता है इंडिया में तो वो 16 लाख में बन सकता है। हमें बहुत जरूरत है। मैं आप सबसे और अपील भी करूंगा कि हमने अपने प्रयासों से पोस्टर पीछे लगाए, आप जाने से पहले उन पोस्टर को देखिएगा। उसमें हमने न्यूमन स्क्रीनिंग की बात भी करी है, रेयर डिजीज के पोस्टर्स भी लगाए हैं। मैं डॉक्टर नरेंद्र मल्होत्रा जी से अपील करना चाहूंगा कि इस तरह का PRO, पब्लिक रिलेशन ऑफिसर भी हो, जो ये बता सके कि कौन सी गवर्नमेंट स्कीम हम इन बच्चों के लिए लागू कर सकते हैं। क्योंकि गवर्नमेंट के पास बहुत सारे स्कीम्स हैं, आयुष्मान योजना है, चिरंजीवी योजना है, प्रधानमंत्री राहत कोष योजना है, अभी रेयर डिजीज पॉलिसी आ रही है। कौन सी योजना में ये वाले बच्चे फिट हो सकते हैं? तो अगर वो एक ऐसा जगह होगा जो उनको समझा सकेगा कि आपको किस में एनरोलमेंट अपना करना है, तो ये उनके लिए हेल्प होगी। मैं एक न्यूज भी आपको देना चाहता हूँ। आपने एक्ट्रेस सुहानी नागर का नाम सुना होगा, वो अभी एक्सपायर है, उसको भी एक स्किन की रेयर डिजीज थी और हृदयांश का मैं बता चुका हूँ कि अभी उसको इंजेक्शन लगाया, वो बच्चा नॉर्मल है। अगर मैं टेक होम मैसेज की बात करूं तो मेरा टेक होम मैसेज बहुत छोटा सा है। रेयर डिजीज सब्जेक्ट या डिजीजेस एक सकरा व घुमावदार रास्ता है जिसकी मंजिल बहुत कठिन है, लेकिन सही सोच, सही टीम वर्क, सही पॉलिसी हमें उस मंजिल तक पहुंचा सकती है। आइए हम मिलकर इनके चेहरे पर भी मुस्कुराहट लाते हैं। बेहतर हो आज इनका, बेहतरीन हो कल इनका, ये शपथ उठाते हैं। मीलों होती खामोशी, बरसों नहीं मनती दिवाली, जब कोई रेयर चला जाता है। सही जिंदगी थोड़ी मीठी थपकी, एक ऐसी झपकी, अब ये कसम। बहुत बहुत धन्यवाद।
Very good message given by you, Mr. Vivek, and I hope all of us will follow your advice and will go for this test and also will look forward to these rare diseases. Look into the problems of this. Thank you so much. So now our next speakers are other than Dr. Narendra Rudra. He is going to talk on what a practitioner should know about genetics. As we all know, Sir is the Managing Director, Global Rainbow Hospital, Director ART Rainbow, IVF, Director Foxy, Smriti, Manyata, Vice President of the Society of Ovarian Rejuvenation, Director Project Positive Health, Rotary, Holistic Fertility. So many feathers in your website. It's over to you, sir.
थैंक यू धन्यवाद। आप इस सब लोगों का यहाँ आज इस हेल्दी चिल्ड्रन हेल्दी नेशन CME में बहुत बहुत स्वागत। So what I'm going to take you through is some genetics. थोड़ा सा complicated है, I try to simplify so every one of us should understand whatever is the speciality, what is genetics, and healthy children healthy nation will be genetics. So genetics, what the practitioner should know, and because if you go to ask for test, and जैसे कि अभी सुना आपने इतनी सारी diseases there genetically. So general misconception was genetic diseases are very rare. No, genetic disorder is always inherited. ये माँ बाप से आता है, ये भी गलत है वो है. Genetic diseases are not treatable, ये भी गलत है. Today we have treatment, and there is no hope for family with genetic disease. ये भी एक गलत वहम है, और we should understand that these misconceptions are there. And we need to clear it. But before we clear, let us understand कि है क्या ये genetics. तो genetics है कि हम जो body खड़े हुए हैं, we are phenotype. Phenotype means हमारा physical appearance है, कितनी height, weight, skin color, hair color. Then we have a blueprint in our body, which is our genotype. Genotype is our blueprint कि हमारी body is made of some genes and कितनी genes हैं. Then we are made up of each cell has chromosomes. 44 autosomes and 2 sex chromosomes. So in pairs we have chromosomes. Then all these chromosomes are 30,000 genes which are there in our body. Out of these 30,000 genes, 20,000 are useless genes. And there are bad genes and good genes. All of us have bad genes. All of us are carrying cancer genes and disease genes. But all of us don't get cancer and don't get disease. Why? Because of the genetics. So अगर आपका your health, your environment, your eating habits, and it's absolutely all right, those genes will lie dormant and will ready. We have a test now, and the test can tell you आपके 30,000 genes क्या है and who's going to develop which type of cancer. But if you get that test done, you will always be scared कि मेरे को तो अभी blindness होएगी, myopia होगा, ये genetic disease might come to me later. So but that test is available. Then all these genes, each genes are their alleles. So we have to understand two alleles. And if they are identical, they are known as homozygous. And if they are different, they are known as heterozygous and homozygous. So each cell in our body contains 46 chromosomes, 23 pairs. 23 are inherited from the mother and 23 are inherited from the father. So we have equal division of our mother and father genes inside. 22 are autosomes and X and Y, or XS is the sex chromosome. So the genome of our body is that all these chromosomes will have all these 30,000-40,000 genes, and all of them are not the good genes. So if we open the chromosome, it's like a bookshelf. It's like a bookshelf. If you open one shell, that is one chromosome on that bookshelf. Whole genes are in like a bookshelf एक library में. आपने एक शेल को खोला, वो आपका क्रोमोसोम, उसमें से एक बुक उठाई, वो आपके उसके अंदर डीएनए, और वो डीएनए के जो वो बुक के जो पन्ने हैं वो डीएनए के न्यूक्लियोटाइड्स हैं, और उसके अंदर जो लेटर्स और लाइंस है वो उसमें एटीपीसी, पीसीजीए, वो आपके उसकी जीन्स के अंदर न्यूक्लियोटाइड की अरेंजमेंट्स है व्हिच डिसाइड कि आप what type of personality or genetic material you have or you are. So our genetic blueprint is our DNA. DNA is located in the nucleus. DNA is wrapped in a structure called chromosome, and we have 46 chromosomes. DNA is made of nucleotides. When you open the DNA, it is a double helix structure which is attached by nucleotide, and these pair correctly. A pairs with T and G pairs with C. So single nucleotide disorders, if the pairing is different, you get SNPs or single nucleotide. So if you understand this, we know which disease is being caused by what. And they are all in this alternating sequences which is known as the DNA code. So this DNA, when you open the double helix, it will open DNA double helix and in between other nucleotides which are pairing with each other like that. So that is what is the genetic. Now out of this DNA, in the DNA there are exons and there are introns. Exons तो है coding area. Each cell को कुछ ना कुछ function करना है. Ovary को ovarian hormone बनाना है, egg बनाना है, testes को sperm बनाना है, male hormone बनाना है, pancreas को insulin बनाना है. So these exons will give instruction to that cell to do that function, to secrete that protein, and that is how the cell works. But a lot of this is introns which are junk, which is useless part of the DNA, which has no use. Abhi tak jo what the research is. Now these genes can be inherited. So if there is a dominant gene, it is inherited as the hair color, the curly hair, the blood groups, the sickle cell, the skin color, the skin type, all those will come as either dominant inheritance or a single gene inheritance. Up now this DNA can have diseases or abnormalities. So where can the abnormalities be? They can be in the single gene, one of the genes out of the 30 genes. So try nucleotide repeat expansions. मतलब nucleotide जो है वो try 3 times repeat हो गए या delete हो गए या insert हो गए या point उसका एक mutate, which will just show you very. Or they can have the number of chromosomes in the full chromosome, which may be aneuploidies or translocations. So what are these? And then how do we test our DNA? We can do from the peripheral blood, from in the baby from chorion sampling or amniocentesis, from any organ tissue, any cell, anywhere, from for forensic, from semen, hair, skin, after rape cases, murder cases, under the nails, that DNA can be tested. From a histological section, कोई section है, आपने हिस्टेरेक्टमी की है, यूट्रस की स्लाइड बनी हुई है, उसके बाद पड़ी हुई है, 10 साल बाद आई कि इसमें मेरा डीएनए टेस्ट हो सकता है, उससे टेस्ट हो सकता है. एंड सिंगल सेल जो बेबी का जो एम्ब्रियो बनता है उसमें से ब्लास्टोमियर निकाल के बकल सेल्स. In when we were students, buccal smear was taken and bar bodies was tested. That was the only test which we had to tell us about our chromosome. So chromosomes can be abnormal in number. Down syndrome, Edward syndrome, Patau syndrome. They can be abnormal in structure, Sharon-Dichschut, DiGeorge and Williams syndrome. Now these are common ones which the baby will be born and these people will live. Other rare chromosomal diseases, they usually abort or die, so we don't mention them or you don't know them. Sex chromosome, X and Y will either Turner's or Klinefelter's. And then single gene mutation, you know, DMDs, thalassemia, G6PD deficiencies, which can go to the newborn, and the newborn needs to be tested for it. So if there is number problem, it may be aneuploidy. Aneuploidy means one missing monosomy, one extra trisomy, two extra triploidies. That means instead of 21 chromosomes का one pair की जगह 3 है, तो triploidy 21 हो गया. एक है missing हो गया. Polyploidies means सारे के सारे chromosome are 3 or tetraploidies. So that is what all the chromosomes will affect as polyploidies or single chromosome. So Down syndrome क्या है? Chromosome number 21. Instead of 2, there are 3. And mental retardation, 1 in 800 babies. So we need to screen them. Edward syndrome क्या है 18. Now trisomy 18 पे 3. Trisomy 13 पे 3 है तो 13 chromosome 13. Why these three are more important? Because these babies will be born live and they will live for at least 20 to 40 years, and there will be a big burden on the healthcare system, on the family, on the society and everything. So it is very, very important for us to screen these, because the rest, chromosome 1 is defective, 2 is defective, that baby will abort. And that will be only in the abortus when you test the abortus. So those will not be born live. So we are worried only about these 5, 13, 18, 21, X and Y. X and Y are Klinefelters, where it is XXY instead of XY, and Turners, where it is only 1X or XO. Now these babies are also, or these adults also come to us with infertility, second primary amenorrhea and the other things. So structure, now these were the numbers. Structure mein kya hai, you know, we have a different chromosome. We have a centromere, we have a long arm, we have a short arm, and in the end we have telomeres. And if you straighten them, if there is a deletion, one part of this chromosome from here is missing. So those are chromosomal deletions. Duplication, this part is duplicated twice, 2 times. Same, so duplication. If it is inverted like this, instead it becomes like this. So the genes come like that. So inversion. Insertion, इसका break करके इसमें invert हो गया, chromosome में inverted. Translocation, from this it is gone here, from there it is come here. Now these will happen when the cell is dividing or when the embryo is fertilizing and the nucleus is dividing. So you can have all these disorders on any of the chromosomes, and depending on where they are, that disease will. So we usually have 22 common disorders of chromosomal deletions which are live born, and that is why the new test which you are seeing, NIPS extended, test for the 5 chromosomes and these 22 disorders which may lead to syndromes. So these syndromes can be picked up here. And so how to do it? For every doctor, every technician who is taking history should know how to draw a pedigree. I mean, pedigree क्या है? They are symbols on how we are. एक male को square में, एक female is mentioned as circle, unspecified sex is a diamond, number of children in the square in children 3 or 2, affected, then they are shaded dark, and non-pertinent carrier, which are shaded with that thing, there is a line in between. Carrier, proborn means the one who has come to you with disease. So these are the adopted out of family, adopted in the family. So you need to draw a pedigree of this. And we draw a pedigree of knowing like this. Mother, father, they have children, male, female, twins, both males, twins, one male and female. So a pedigree is drawn like this. Now supposing this person has come to you with disease, so आप इसको dark कर देंगे. And then you trace 2 generations up, ये कहाँ से आ रहा है? If that history is known. So pedigree आप draw करके रखेंगे, abortion is abortion. Or instead of drawing these squares 3 times, we can also draw 1 square and write 3, and 2 girls we can write 2. So in 1 square. So that is how a pedigree chart is drawn. If it is affected or disease, then you darken it. If it is not affected, only carrier, you half darken it. If it is a sex-linked, you put a dot. If it is dead or aborted, you just put a cross. So this is very important on us. We एक ही pedigree draw करने से you understand इसके कितने बच्चे हैं, कितने affected हैं, कितने को abort हो गए, कितने dead. So that is how a pedigree is drawn, and this pedigree drawing everyone should know. So this is a recap of what the pedigree. So this will tell you if it is autosomal dominant. Now this father is affected, mother is okay, so she'll have 1 affected female and 1 affected child. So when they come to you, you can give, you have 50% babies will be normal and 50% will be affected. And that is how you do. Autosomal recessive has both are carriers, so there will be 2 carriers, 1 affected and 1 normal. So they have 25% chance of having a normal baby, 50% chance of babies being carriers, and 1 will be infected. So how it will help you in counseling? What it is. If it is X-linked, then X chromosome carrier, then it will go by on the all the X. So that is what will give you an idea of what genetic disease. So what autosomal inheritance is, what autosomal recessive inheritance is, and these all have to be read and understood. I'm just giving you an overview that for genetics, this how important it is to know all these marks. Then there are very rare ones which we are talking. Autosomal mutations, genetic mutations, genomic imprinting. The chromosome genes can get interchanged, imprinted, disomies may be there, gene environment interactions with it. All these can be done, picked up if you are doing a correct genetic. So, pedigree will tell you inheritance pattern, recurrence risk, prognosis of the disease, counseling of the family, whether she has a chance of normal or not, and our role as a clinician, whoever you are, physician, anyone, because this disease can go to anyone. They will have to ask a history, draw a pedigree, and if the pedigree pattern shows, then they can talk. And this could be for diseases like juvenile arthritis, for rare diseases where genetic evaluation needs to be done, and the types of tests, then you say what test I want to do, whether you want to do karyotype, whether you want to do carrier, whether you want to do newborn screening, forensic test, or for research. So this will give us an idea on what tests we need to be applied. So snapshot test for some chromosomal analysis, karyotype, abortus material. Don't do karyotype, you have to do microarray. For TORCH testing, always do with PCR. TORCH IgM, IgG is not a good test, and because a lot of times patients get confused because IgG will come positive in most of the population. That tells us that we are already immune to it. DMD, biopredict panels, recurrent abortus panel, infertility panel. These panels will come like this, and these are the rare diseases which we can test in people who want to get. So our role as a genetic counselor, the patient will come either to the pediatrician because the baby is born and gone there, or to the obstetrician, or to the general physician, or maybe to the GP. So that's a good rapport. So that family will listen to you. So this is why we need to tell them that there is something like genetic disease, and it is a subspecialty, and you can go in for further testing and for further prevention. So as a GP and as obstetrician, you have to be the one who will be doing the first counseling and first consultation and making a pedigree chart, and then giving them a solution on what test to do and how to diagnose disease. That type of sequencing, you can get your genome sequencing done. What disease genes you are carrying? That is possible today with that. So thank you very much for attending this, and this is just a brief outline of what genes are.
Thank you very much, sir. It's been a nice, refreshing lecture. I mean, you had always been a wonderful auditor, and first time I heard you when I was in MBBS. You took a lecture in 94, I remember. And sir, इतनी अच्छी genetics MBBS में कभी समझ में नहीं आई, इतनी अच्छी आज समझ में आई. I can teach it also after this. Thank you so much.
So I have a question to ask. Suppose as a radiologist, I'm looking at a condition which requires the genetic testing, and because we have the cafeteria approach and we offer them amniocentesis or CVS, and they don't agree to it, so they get it aborted. So I just wanted to know can they be counseled to get the abortus tested genetically, because then at the next pregnancy again we are at a loss. So can something be done to promote this counseling to the patients, because after they have got it aborted, then they forget about it, and then they remember only when we have the next pregnancy and we are at a loss, we don't have any next case.
So very common problem here. When they come, as it is there in brief, we just have a similar patient just now. The Harika just want to do a DHC for it. I had counselor just before the CAD, try me, but want to know the reason, but don't want to get a test. So what to do? And stillbirth has happened, and they don't want to get a baby a toxid or the test. Nahi is for toxid. And they are saying कि कैसे हो गया, they get angry. So what is the best way to do is take a blotting paper and a drop of that blood from that stillbirth baby, just from the cord or anywhere, or a prick or a skin, there is a skin cut on a blotting paper, put it in a plastic there and put it in your fridge. with a label. They'll come back after 10 days, वो तो genetic test कराना, so you have the genetic material. So you store the genetic material. Of course, we're not going to use it, it's an expensive test. But if they come back asking you, then you say we have the material and we can get that tested right again now. And you okay. So we can do
Drop
that.
of blood is sufficient.
Absolutely, one drop of blood, one hair, because a hair, whole genome can be.
Can you keep a cord?
Anything, just a little bit of that. You know how the mammoth elephant has got extinct, you all know that, and they're trying to resurrect the mammoth. अब उसकी जीन्स कहाँ से मिली? अलास्का में एक मच्छर के ब्लड में वो एलिफेंट की जीन्स मिली, उससे उसका पूरा जीनोम उन्होंने बना दिया, डायनासोर का जीनोम बना लिया, just because something was in the ice that mosquito was buried in a scientific experiment. They did testing, they found the elephant's gene in that mammoth. So the science is gone, just need one drop. Thank you.
One more lecture by Dr. Mrs. Sarika Modi on role of patient support group.
Hello all, respected doctors, dignitaries, nursing staff, Rainbow IVF, Ujala Cygnus, Meta Hospital. I am Sarika Modi, along with Mr. Atul Khandelwar from IVM Support Charitable Trust, and along with Mr. Vikas Bhatia and Poonam Bhatia from World India Foundation. So by now, I think you must be knowing about the genes screening, and you must be knowing how the parents or the families to deal with this, because they are with the burden, non-stop, continuous burden about everything, because once they come to know that yes, the baby is having some gene defect in their body, so they get paranoid. And of course, the financial burden, emotional burden, and the society burden, it is always there. So we as parent support group, what the work do we have? We as parent support group, we take care of these families by counseling them. So counseling is a very important tool. At times, we handle parents as if they are our own relatives. So they believe us because we are PAG leaders. PAG leaders are the parent advocacy groups that we have, that they have so much faith in us that so we become their counselors eventually. So we have to counsel them with the food, with medicine, with awareness, with the number of laboratories which are there in the country. So there are so many laboratories to investigate NBS, and of course, ma'am has said, sir has said that NBS is such an important thing. It's such a small test, but it prevents so many, not prevents, sorry, it manages so many things. So it is very important to create that kind of awareness among the hospitals, among the doctors especially. Once the child is detected with some kind of disorder, so out of 7,000 rare disorders, there is one kind of disorder, that is inborn errors of metabolism. We as World India Foundation and IVM Support Charitable, we take care of this particular disorder. Previously there was no food and medicine, so which can be utilized, which was available in our country. It was all imported. So it became so much burden, financial burden on the family. But with the help of FSSAI, Diet for Life program was initiated. And there are two companies in India, Pristine Meta Nutrition and SP Foods. They are from Bangalore, and they provide food and medicine for these children. And this way, the inborn errors of metabolism has started getting managed. The government is working so hard that now we have 11 Center of Excellences all across the country. What is the role of 11 Center of Excellences? These are the hospitals which are 100% equipped to handle rare disorders in the country. The names are AIMS Delhi, Maulana Azad Medical College Delhi, Sanjay Gandhi Postgraduate Institute of Medical Science Lucknow, Postgraduate Institute of Medical Education and Research Chandigarh, Center for DNA Fingerprinting and Diagnostic Hyderabad, King Edward Medical Hospital Mumbai, Institute of Postgraduate Medical Education and Research Kolkata, Center for Human Genetics with Indira Gandhi Hospital Bangalore, Institute of Child Health and Hospital for Children Chennai, AIMS Jodhpur and AIMS Bhopal. So whosoever, I mean there are with the help of ORDI, that is Organization of Rare Disorders of India, now we have set up 2 counselors, 2 coordinates who help these families when they are sitting in the OPD, and the families, the parents, they come that, see, I have this problem. Of course, if a family is sitting in a genetic department, that means that person, that family is affected family. So, but with such a big structure, such horrifying experience they must be having, so it becomes very difficult for them to, convey their messages. So then we have set up 2 coordinators. One is in and one is in Hyderabad Fingerprinting Diagnostic Center, Hyderabad. So what they do, they counsel them, they register them, they sit there, they fill up all the forms, whatever required, and they, of course, they guide them for everything, and then they try to just convince them that please do the regular follow-ups, don't get disheartened, and they just talk like family, so that the things become more easier for them to handle, that their plea is being heard. That is the most important thing. So the government is doing a lot of things, as I said. There are UDID cards, that is Unique Disability Card. As we have Aadhaar cards as normal Indian citizens, these children, the government has started the UDID card for them. It has a lot of benefits. Benefits like education, benefits like traveling, railways, airlines, work in future. So we have parents whose children are now doctors, engineers. They are going to colleges, they are going to schools. We have Mr. Atul Khandebar with us, and his grandson is affected with MSUD, and his grandson is doing perfectly fine with the help of doctor's treatment and counseling and regular follow-up. So it is very inspiring for everyone that once it is detected at an early stage, that is the most important thing. That once it is detected at the time of birth, during 24 to 72 hours, then everything can be managed as far as IBM is concerned. So the government is doing a registry for rare disorder, because since it was an unknown subject for India, so the government has started a registry for India. Through these Center of Excellencies, this registry is getting maintained, so that census is there, so that the companies are aware, the pharmaceutical companies can come up and create some medicine. There are very simple medicine called sodium benzoate. Everybody knows. IV is required, but it is not there in India. And the companies are not agreeing to create this medicine for India, because they ask for data, and the data is not available. So the government has created these COEs so that the data is created, so that registry happens, and then they can, of course, ask the pharmaceutical companies to at least create these particular medicines which are required for various rare disorders, not only IBM or any one particular disorder. There are so many disorders. So I will, of course, request your hospital also, so that you also create some registry, you also create some data, so that we can help the government to have some benefits for all these rare disorders. There are so many government projects. That is one I told you, the UDID certificate, that is Unique Disability Card. Then there is Nirmaya National Trust Insurance. There are railway travel concession. newborn screening, we are, of course, we are pledging and we are creating awareness, and the reason of doing all these seminars and CMEs are that we want this newborn screening to become a universal program for India. Each and every child which is born, that child has a right to at least know its own body, so that at least we know, even the parents know, the doctors know that what has happened to this child. It is I think it's a birth duty, birth right for that child to know about his or her system. And then of course FSSAI is helping us a lot for the Diet for Life program. So there are pharma companies, as I told you, there are Pristine Meta Nutrition, SP Enterprise, and we as parent support group, if a child is born with inborn errors of metabolism, and if that family is below poverty line, so we give 100% support by giving lifetime food to that family. In case that family is a bit well off, if they can afford, then we do either 25% or 50% or 30% sponsorship. But we try to save that child. If the family says that, see, I don't have money, I can't spend so much, so please can you help us? So we say, okay, we will do that. So I think in every week I get, I think, some 2 or 3 calls from various hospitals all across the country. Yes, day before yesterday I got a call from Karnataka hospital, and the doctor said that this child is born with MSU. I said, okay, fine, so I will send the food. Then next day he called me again and he said that no, don't send the food because the family is still deciding that whether they want to continue with this child or not. So then there comes the role of a counselor. So I told him, the doctor, that see, we have counselors also. If you want, if you think that the family is willing to listen, willing to talk, then our counselor can every time talk. It is of course free of cost. We don't charge anything. It's just there. So he said, no, okay, I will just see if that family is willing or not. So that's totally up to you. So this is the role of parent support group we do. So I will request all the gynecologists sitting here, and in case, of course, you all know every gynecologist in the city. See, the families are with you for good 9 months. The mother, that girl, listens to you wholeheartedly. Whatever you will say, they will follow, they will agree. So whatever test you tell them, they go and will just do it. I would request you to ask them to do this newborn screening test also as soon as that child is born. So that at least, number 1, we can create the census. Number 2, which is most important, that if that child has a particular disorder, that child can be detected in an early stage and we can do something for that child. So this is the only reason for these CMEs and seminars. And I hope, because the pattern in the doctor's hand, we as parent support group we are like a kind of bridge between the families and whatever the requirement they have in terms of government, doctors, psychologists, counselors, physiotherapists, whatever they need. So it's a collaborative thing. We need to really work as a team so that we, as what the topic we have, we can give healthy child for this healthy nation, and our governments are happy with us. That's it.
Thank you.
Thank you.
Thank you, Ms. Modi, for giving such important information about the your project, and we should all be aware of what is the importance of this inborn error metabolic now.
With this, we have come to the end of our first session. It was really our privilege to hear from channels like Dr. Jaydeep Malhotra ma'am and Dr. Naren Malhotra sir. And a special thank you for our esteemed panelists for your valuable time. Thank you, sir. Thank you. Moving on to our second session, which is a panel discussion on healthy children and healthy nation. First of all, I would like to call upon our panelists, our moderators for the evening. Dr. Sangeeta Chaturvedi ma'am, she is our dynamic AOGS secretary and IMS secretary. And I would also like to call upon second panelist for the evening, Dr. Sanjeev Agarwal sir. Dr. Sanjeev Agarwal sir is the Vice President IAP Agra and ex-Secretary IAP Agra, leading pediatrician in our sector. Thank you, sir.
Panelists too.
Good evening, my seniors and my colleagues, friends, all present here in this hall for very important CME on healthy children and healthy nation. I welcome you, and it was the previous session were very important and very informative, and we came to know so many things are going in our country, and we should be aware of it. And now we understand life doesn't begin at the time of birth; it begins intra-uterine. So and as we go by definition of health, it is physical, mental, social, and spiritual well-being. So we have to work on all of these points to get a healthy child and a healthy citizen. So it is not the role of the one person; it is the teamwork, and it should be the role of obstetrician, role of pediatrician, and role of government, role of the school authority, school connect program, and social group and NGO. So, as a medical person, we have more responsibility. And as soon as a couple wants child or they plan for pregnancy, the first person they meet obstetrician. So obstetrician has more role, so more responsibility. Then comes pediatrician, but it should be as teamwork, and it should be collaborative efforts. So now I call my second moderator also. He will tell overview, and I would like to invite our panelist, Dr. Ujala Cygnus. She is very senior gynecologist and practicing in Jaipur House, and she has passed from SNMC. Second panelist, Dr. Gayatri. She is also very renowned gynecologist of our Agra, very humble person, and she is practicing near Manas Nagar colony. The third panelist, Dr. Manpreet Sharma. She is very hardworking, and she is here in Rainbow Hospital itself. Welcome, Dr. Manpreet Sharma. Then Dr. Nidhi Bansal. She is young, dynamic, very hardworking gynecologist, and she is working in SR Hospital, Namdel area of Agra. Now I hand over mic to Dr. Sanjeev Agarwal.
Good evening, everyone. Without wasting much of the time, I would like to invite my pediatric panelist, our esteemed Dr. Ujala sir. Please have a seat on the desk, sir. Dr. Anand sir. We are here with the team of very experienced and seasoned pediatrician, so that they can reply the answers very well. And Dr. Akan sir. Sir, please have a seat. Dr. Akan sir, please have a seat on the desk.
Thank you.
Ma'am is saying that gynae comes first, or you should always initiate the second. So I think I am all the microphone, ma'am, and obviously gynecology should be learning being a pediatrician. Please.
सर बच्चा तो बाद में आएगा हमारे पास। So as we know, children are vital for nation, present and its future. And in recent years, there has been an increased focus on issues that affect children and on improving their health. There has been great deal of progress in reducing children's death and diseases, as we came to know today itself. Several other indicators of children's health point to the need of further improvement. We know the definition of health. So my first question goes to Dr. Nidhi Bansal. How do you see role of obstetrician for healthy children?
First of all, thank you, ma'am, for making me a panelist. And as Jenny ma'am told in her first lecture, that if any assault happens to a female, pregnant female, that thing can be carried over to the two progenitors. So, as an obstetrician, we are the first and foremost person to help a couple in their journey towards the parenthood. So, the dictum is the healthy mother can only produce a healthy baby. So as obstetrician, our role starts right from preconception period, antenatally, postnatally and intranatally, and sometimes few weeks after delivery also. So my goals for a patient, for an antenatal patient, or our goals to be for an antenatal patient should be a healthy mother and a healthy child at the end. Treating and teaching of the parents regarding the parenthood, proper clinical testing which should be evidence based, and proper immunization of the patient during pregnancy, and taking care of any complication if arises. So, as obstetrician, our role is very important, and we are the pillars for making a healthy nation. So, we should be very careful with dealing with the antenatal patient.
Definitely. Not when they are planning and if they are having infertility also, fertility issue. So our role starts from there, counseling and treatment. As a gynecologist, what would you do in counseling and preconception visit? Dr. Gayatri.
We have heard the importance of preconceptional screening by ma'am just now. A lady who is coming to us should be, who is planning for a baby should be mentally and physically fit, as she has to nurture a healthy and a life inside her. So when a couple comes to us, we should counsel them about when to plan a pregnancy, what they should take care of, just like age, very important, that it should not be a teenage pregnancy. Then it should not be a pregnancy after 35. It has its own complications like genetic disorders, then preeclampsia, eclampsia, and PPH like that. Then nutritional status of the mother is very important. She should not be anemic. If she is anemic, if she has any deficiency like we have just heard iodine, folic acid, and all this should be corrected before she is planning for a pregnancy. Then she should not be obese, undernourished. Everything has to be taken care of. Then genetics is of course a very integral part of preconception screening. Any history of thalassemia, cystic fibrosis, or muscular dystrophy should be taken, and if it is like that, or any family genetic history in the family, then she should be counseled or she should be offered genetic counseling for this. Then we should emphasize on environmental factors like epigenetics play an important role in this.
The work pattern.
Her work pattern, any stress, any exposure to radiation, exposure to these pesticides, insecticides, all should be taken care of.
More of traveling.
Traveling or if anything like that. Then other substance abuse, like if she is taking any alcohol or smoking, that should be discouraged, and it affects the health of the baby. And anything
Contraceptive history. When she is coming for second child. So preconception that also includes. Contraceptive
we should emphasize that she should take at least 3 years in between the two babies. So if she's planning for a second baby, then we can ask her that she should take care of this, and so she should be healthy before planning for a second pregnancy.
Any other point?
Her mental health, her psychosocial, any domestic violence, like they should be taken care of. She should be counseled very nicely about this.
Other points? Male partner. So it comes, then drug history. Anyone can answer.
History of drugs regarding hypertension, diabetes, epilepsy, antipsychotic medications, or some other anti-anxiety drugs. If she is taking, we should be more careful towards, and we should taper, or we should shift to drugs which are not helpful to the fetus, which are not harmful to the fetus.
Infection.
And moreover, HIV, HPV, HCV, and STI, and asthma or RTI, other infections, chlamydial infections, etc. We should take care of all these.
What other things we can do?
Lifestyle diseases we should also know about her lifestyle, or is she suffering preconceptually from any lifestyle disease, especially diabetes and hypertension are very.
Some other
Occupation hazards.
yes. Occupation hazards, radiation, or very stressful work, long spending. Yes, chemical exposure. Then obstetric history, that is also important. What happens in first check? Bad obstetric history or any problem, congenital anomalies. So we will be more careful in this pregnancy. Then substance abuse. That is what we think. The tobacco chewing, the manjan, tobacco smoking, and the population, the rural population, it is very common in every state of life. It is common. Alcohol, smoking. So we have to counsel them accordingly. You have to equate that these are the hazardous effects of these addiction. Then immunization we have to So all these things you will see, the age, family history, the hypertension, cardiac, genetic civilization, concept, all we have covered. My third question to Dr. Ida, what immunization we can offer to a lady for healthy babies?
The immunization that we should offer first and foremost, the routine immunization that she has been immunized with tetanus toxoid, has taken the 28 to 30 weeks of pregnancy, has to take that vaccine. Apart from this pneumococcal, then we have to ask her about the history, whether she has taken rubella vaccination and has she taken any other vaccine like HPV. We all should know, and if she has not taken these, we should counsel her to take these vaccines.
She is coming in,
and if she is a high-risk worker, working in places where she can be exposed to hepatitis B, we should gain the growth, we should give her that vaccine.
If she is coming in preconception, then she should be vaccinated for tetanus or Tdap, then hepatitis B, HPV vaccination. But once she is pregnant, and we can offer limited vaccination.
Then we can offer very limited vaccines. That is our tetanus toxoid, our Tdap, pneumococcal vaccine, which are the main ones, and influenza vaccine. In short, is very important. And hepatitis.
And counsel for the rest of our
postpartum period, she should be there after delivery.
We have to counsel her. But she has taken like HPV vaccine, she has taken one, and she asked her
vaccine.
Not
During pregnancy, HPV cannot be.
Because it is.
So if she is taken one dose and the second dose is due, it will be delayed by till delivery. postpartum and then the third dose to be followed.
No, Dr. Manpreet Sharma, apart from routine standard antenatal care, what special situation you will take in consideration which will affect future health of child?
Now, normal antenatal care has been taken care of by all the gynecologists here. The other things which we should know about, first is patient coming to us, in which age criteria is she there. See if she is rather teenage girl or a girl, lady who has completed her 30s and is in late 30s. So accordingly everything changes. Like if she is very young, she has to be told about all the nutrition, vaccination, and the partner should know that she has to be taken care of because she is very young accordingly, and maybe that she may need assisted delivery. Hence, the same way if she's elderly, so elderly patient, but not patient exactly, elderly antenatal woman coming may have other associated diseases like thyroid and hypertension, sugar problems, and she may be having PCO treated or IVF treated, infertility treated patients. So in this, they have to be taken into consideration that their hemoglobin level, even for the younger woman also, hemoglobin level should be maintained. Her thyroid, blood pressure, sugar levels, in previous 3 months also, how was her sugar level, and have they undergone DIPSI test, gestational diabetes, she has to take care of.
So mainly, apart from routine antenatal care, we have to look for the other risk factors, other diseases,
Absolutely.
and special care to be given according to that. She is having HIV or organ, after she is coming after organ transplant. So many things we can keep in mind, and we take care of lady according to that.
And otherwise, if she is having HIV positive, hepatitis B, C
but we are focusing on female only. We are talking about healthy child. So we have to counsel according to her. We have to take care of baby, more investigation, more care, and during at the time of delivery, special precaution. And we have to take pediatrician also with us. So the newborn screening according to pediatrician. So pediatrician panel also we
had even organ transplant हुआ है. अब organ transplant में immunosuppressive दे रहे हैं, तो उस टाइम पे पेशेंट को काउंसिल करना है लेडी को कि that she should not get pregnant during the immunosuppressive therapy, and after that also if she has undergone liver transplant or a kidney transplant, accordingly all her measurement, all her data should be available and it should be controlled totally. And after that also, when she go for vaginal delivery or a cesarean section, most probably she will go for cesarean section because vaginally it will again give
more and more counseling and making her aware of her situation and making her prepare for all the consequences. And decision is hers. She should know what status she is having and what outcome can be.
And according to, even for HIV patients, if the viral load is heavy, they should be taken up for cesarean section. If the viral load is very low, they can be tried for normal delivery.
So, fifth question is safe delivery is utmost need. How we can achieve it? Anyone? Dr. Lady? Safe delivery is a need, and how we can achieve it?
We should have trained medical assistants
Yes.
trained nurses or trained doctors
Equipment.
who are doing for delivery, who are doing deliveries, then proper equipments, high obstetric emergency situations should be dealt. We should have an access to
it should be
access to any
accessible.
emergency situations which can be there. And
Blood.
any complicated deliveries, yeah, blood banks and all should be nearby.
So all these things, access to emergency obstetric care, preventing birth injuries and complications like in diabetes when baby is macrosomic, so shoulder dystocia or any other injury. The postnatal care, if HIV positives, then take care of baby giving ARV. Yes, ma'am.
If the mother is diabetic, if shoulder dystocia, to prevent the neonatal hypoglycemia, proper sugar monitoring and early feeding, early cord clamping. If the mother is HIV positive, then early cord clamping and never syrup or zero risk prophylaxis for the baby. And if it is multi-parenting, then prematurely is a major concern. Then the neonatal care, proper and ICU care should be given, and the neonate should be screened regarding the prematurity problems.
And our paramedics should also be trained accordingly.
Collaboration of the two is a must or a very safe delivery.
Last question, do you think technology advancement in obstetrics is helpful in reducing maternal and child morbidity and mortality?
I just want to share my thoughts before we go for the second. Most important thing we are lacking is that the pediatrician is called after one the child is delivered. It should be mandatory. In fact, if it is possible, everywhere the pediatrician should be informed, and wherever affordability is there, the pediatrician should be there at least 10 minutes with arranging it, because first 5 minutes sir, I'm not talking about that. The scientific
अभी जाओ अभी आ रहे चलो अभी आ रहे गाने लग गया भाई तो आ जाओ
or it always very, and most important scientific thing, it is only sir, it's the first 5 minutes of life which is going to designate
absolutely must
sir, it's going to designate whether the child is going to become a postmaster or he is going to do the IAS. The intelligence, yes, everything changes in 5 minutes. If you go through everything, so 5 minutes, because we are very happy, child to revive हो गया, रो गया, भाई साहब वो चौकीदार बनेगा, कुछ नहीं.
And patient profile should be known to
Just
the
all the gynecologists, team gynecologists are steady. This is important, and you should arrange your pediatrician at least, or the pediatrician should be in the capacity.
or you marry a pediatrician.
So the married one will never end.
Right. Dr. Raji, please highlight this newer technology and it can be helpful in obstetrics and for having healthy baby.
Yeah, we have high resolution ultrasounds. We are doing fetal anomaly scans now. Early anti-anomaly scans we can, and color doctor, we can predict risk of preeclampsia later in pregnancies. And color doctor assessing, telling us about the fetal growth retardation.
Like heat also
We can treat and equine also. So it is very much advanced now. Then we have prenatal genetic testing like NIPT, coronary pillar maps, amniocentesis, all.
So madam must tell the healthy embryo only is transferred, so genetic testing is transferred.
Which has now come up, and we are doing these routinely now. Then we have
fetal monitoring devices.
Fetal monitoring devices.
So during early assessment, monitor hypoxia, we can prevent so many.
And latest now there is AI has come.
Yes.
AI has come. So we can feed the medical data and AI will tell us about the any high risk factors about the patient.
And it is plan surgery, robotic surgery, then gene editing technology.
Gene editing technology has come and we can
So it's not
right time.
it's not a common lead, but these things are there now.
They are just coming up.
So thank you. I hand over my mic to Dr. Sanjeev Agarwal for further comment.
Thank you, ma'am. Finally, the ball is in our court. Baby deliver. Now we'll take care of the baby. So it's a great pleasure to be a part of this wonderful session. I would request our esteemed panelists to get ready for the questions. So without wasting much of time, I would like to start with the question. Sir, Chandra sir, this question is for you. What are the foundational elements of a healthy child, both physically and mentally, and how do each contribute to building a healthy nation?
The foundational elements which are important for a healthy child. First, I'll talk on the physicality. The first thing is very important there should be physical wellness of the child. The second important thing is easy access to the healthcare. That is fundamental. And the third thing, we should ensure the proper nutrition. And lastly, in the affluent societies, what we are doing, we are giving proper nutrition, but not looking after their physical activities and exercises. So all these four components are very important as far as the physical thing is. As far as the mental thing is concerned, emotional regulation is very important. The children should be emotionally regulated. The parents should work on that, and so many things are there going on in the society that the emotional stability of the children is disturbed. Second thing is resilience. Resilience is something we make children how to come out of a difficult situation. If they should not get nervous in exam, they should not undergo any pressure, they should not go under the pressure of any of their siblings or their friends. So that resilience should be. So emotionally, these two things are very important. We have to.
Very truly said, sir. Because health is a state of physical, mental, and social well-being. So
I want you to complete that these things if we do, how this is going to help the nation. This will get the cost of the healthcare down. This will get our children in the school with a better performance, and we will be nurturing and fostering a very productive things. This is how the nation will be handled.
Let's move to the next question. This question is for Dr. Arvind Bedi, sir. What role do you think the parents can play in promoting healthy lifestyle and behavior among children? And how can we better support them in their efforts?
Thank you, Dr. Steve. So there are two components of the question. One is what is the role of parents, caregivers, and educators as far as care and nutrition is. And the second part is how can we help these group of people for better child care. So these parents, caregivers, and educators play an important role in modeling the health behavior, providing supportive environment, and they help in teaching skill development. So these they do with the help of resources, with the help of education, and with the help of a supportive mentor. So our aim is to strengthen this group of population so that we can provide better care for children. So how we can do? Parents and caregivers. These can be supported right from the conception. So IAP goes for a program 1000 days, that is 370 days of the pregnancy, and 630 days after pregnancy, that is 2 years of age. Then this is supported by early childhood development group, which caters for 0 to 3 years of age. Because the brain grows fastest between 2 to 3 years of age. So this has to be taken care of. The parents and caregivers have to be made aware of the child's development. Then after the child reaches the school or preschool or proper school or transforms into a young child or adolescent or young adult, there is the responsibility of the educators. So they have to be trained and sensitized so as to pick up problems such as slow learners, learning disabilities, autistic spectrum disorders, or ADHD. Because these children need support. They are not to be labeled as a stigma or a taboo. So the educators, they are provided with the information from the pediatricians. So this we have been doing as far as in the form of ECD workshops, early childhood development workshops, and for the sensitization of the educators, we have been doing with the board development and behavior disorders various workshops for the teachers.
One more question. Yeah, Mr. Radha.
I'd like to add one word. I think the only answer to this is be a role model. Whether you are a parent or a caregiver or an educator,
how can we, like, we get all the information on WhatsApp only. तो हम लोग को तो बहुत ज़्यादा WhatsApp देखना पड़ता है. The child, they are not supposed to take much time for screening actually. Then यही मेरा question था जो is sir, in this era of digitalization, what do you think? How can we ask the children to stick to a particular screening time? As we used to teach the parents, 30 minutes would be the maximum screening time. And in this era of digitalization, well, every class is there on online mode. So how can we? This is the biggest irony.
See, technology is one thing. Screen exposure is one thing, which has come to our rescue in the last 4 years. उन 4 साल से पहले कोई भी स्क्रीन टाइम के बारे में ज़्यादा बच्चों को खास तौर से एक्सपोजर नहीं देता था, बट इन द कोविड टाइम screen came to the rescue for the children as well as adults. So technology is one tool which is a double-edged sword. So we have to strike a balance between the screen and the physical activity. What is screen taking? Screen is giving us information, screen is making us knowledgeable, but at the same time, this screen is stealing time away from the physical activity. Children are getting more towards screen, they are getting away from the physical activity. So we have to strike a balance between the screen and the physical activity. As far as IAP is concerned, below 2 years of age, zero screen time. Below 2 years old. And I'm sure all the pediatricians are experiencing that उनकी मदर बच्चे को लेके आती है कि सब ये तभी खाना खाना है जब उसको मोबाइल दिखाते हैं. So the mobile दिखाते तो खाना खाना है. And as far as early childhood development group is concerned, as at the feeding time, there should be only 3 things. One is child, one is parent or caregiver, and third thing is food, without any screen. So the child knows what the child is eating, and the parent knows that the child is relishing the food. And it is the opposite thing which is happening in the society. Below 2 years, IAP recommends 0 minutes screen time. 2 years to 6 years, it is advisable to go for approximately 20 or max 30 minutes per day. After 6 years of age, non-academic, the screen time has been divided into academic and non-academic. Non-academic time should not exceed 1 hour. And because screen is one thing which is inevitable when the child goes to a higher class, adolescent or younger stage. So one should follow the rule of 20-20-20 because the problem is digital strain is increasing. So we should follow the rule of 20-20-20, and it is a very simple rule. After 20 minutes of screen usage, please go away from the screen for 20 seconds and gaze something 20 feet away. So 20-20-20 is one thing which we cannot follow. And on a light, analyze for yourself how many of you are looking towards the screen right now.
very
charity begins at home.
This is the biggest eye opener. I think 2020 के टाइम चल रहा है वैसे भी सर. तो I think ये इमोनेट सबको याद रहेगा क्योंकि अभी 2020 भी चल रहा है.
What I feel that the screen time and so many things, the generation of today, they hardly listen to the parents. In fact, they are so much pampered that the parents are afraid of it. They want the child to be always happy. They will never say, they will never fight. So this is the drawback we are having. What has happened, our generation is a sandwich generation. When you used to come back from the school, we were told your father will have the meal first, then you get it. Today, the child is already pampered, the father is coming, then he has to eat. Then in the afternoon, the father was sleeping and we were told, don't get quiet, father is sleeping. And today, this father comes in, told by the mother that child is sleeping. So, it's a sandwich thing. But my dictum as a pediatrician, I advise the parents, it is very, very simple. You have to be very strict to your child. You should take away the mobile or other things. And once you do it, let them be unhappy for some time, but be harsh. Because the future doesn't.
Sir, what is the advice for the patients? Your patients, many times we see rowdy children who are trying to literally turn the things upside down within your chamber. And the parents are smiling, and mother is very happy and proud. My child is very naughty, and he is slapping. And they're very happy that
So,
child is notorious.
you have to analyze the attachment of the parents with the child and the attunement of the parents.
How do you control these and what advice do you give to the
Keep a packet of coffee in your parents.
You look at, you please watch the movie Abhut Matritva, you'll understand.
And for the information,
Send the link. Yeah, I'll send the link.
IFP has.
Let's move to the next question. But we are getting. So this question is for Dr. Akansha. Dr. Akansha is our very own internship in the hospital. So, Dr. Akansha, what are the challenges and opportunities in addressing mental health issues in children? How can we integrate mental health support into school and healthcare systems?
Thank you, sir, for the question. Firstly, I would like to thank you and everyone present here for choosing this among such senior pediatricians like Dr. Vivek. Coming to the question. Sir, according to me, the most important challenge in addressing mental health issue is the recognition of the problem. We all know the most common sufferers of mental health issues are generally adolescent age groups. But even nowadays, even children as small as aged 4 to 5 years, they are also facing mental health issues in the form of extreme anger, extreme violent tendencies like breaking expensive things at homes for not just fulfilling their small wishes. So firstly, we have to recognize the problem, and then for solving it, we can take easy access to counselors and therapists, which we can employ on a regular basis in schools, in our societies.
Some tools are there like ANFAT is there.
Yes.
So we can identify ADHD and autism
Yes.
and life illness.
Yes. And of course, by promoting resilience building programs, integrating mental health teaching and development programs into schools and health.
Some elevated programs are also always there.
Channelizing the energies is also very important.
Yes.
In some constructive.
One important involving them in extracurricular activities in playing games.
Yes, Dr.
जंक फैमिली में शुगर वगैरह बच्चों को भी erratic होता है. The moment they take sugar or junk, then they have a high kick and they have a very aggressive behavior. Once the sugar goes down, they become dull and very cranky. So we have to control this urge to give junk and sugar to your baby as well.
Refined sugar intake. So next move to next question. Dr. Ujala, in what ways can early childhood education and development program impact the long-term health outcomes of individuals and the nation as a whole?
See, education is a very big role, and as early as possible, if the child is put in the education system, there will be definitely growth in the cognition of the child. As early cognitive journeys of the child increases, the intelligence of the child becomes, his productivity and thinking will be. Secondly, what I feel is, there is, if you do the early education, there will be enhancement in his academic as fast as was.
Now schools are there for children with special needs actually. So you mean early stimulation.
9 साल के बच्चे को स्कूल में डालना चाहिए.
नहीं सर. Early stimulation.
Education.
Sir, schooling.
Education doesn't mean school. Education means you should parental education as well as schedules.
Teaching can begin at home, sir.
That has
In utero, yeah, right.
Education doesn't mean sending the child. Canada education
As we learned recently, अब्दुल मातलो को मैम ने बताया जैसे कि अभिमन्यु का एग्जाम्पल मैं मानता हूँ।
संस्कार को घर में दे सकते हैं ना बच्चे को। शुरुआत से 2 साल के बच्चे।
Nowadays the children are mostly dependent on maids. Working mothers they have just.
ये किसका फॉल्ट है मैडम? ये हम ही लोगों का फॉल्ट है ना? हमारा ही फॉल्ट है।
तो आप मेड्स को संस्कार दो।
मैडम saying rightly that maid को आप एजुकेट करो और मेड आपके बच्चे को एजुकेट करेगी। So that is like indirectly teaching the children. Very good. So let's move to the next question. This question is for you. With the rise of technology and screen time, ये हम लोग डिस्कस कर लिया था. So let's move on to the next question. Now, this question is for Dr. Akansha. Dr. Akansha, how can we empower children and adolescents to become advocates for their own health and well-being, fostering a sense of agency and responsibility from an early age?
Empowering children to voice their concern and need for health issues is the most important thing for becoming advocates. But how will and when will they voice their concern? They will voice their concern by building up their confidence. So we have to give them opportunities, like leadership opportunities, or maybe involving them in small decision-making processes so that they can voice their concern. And when will they voice their concern? We have to educate them on common health topics, on maybe what may be the warning signs or what may be the red flag signs when they need to voice their concern to their parent or maybe other teacher that mama or teacher, I am facing this kind of situation, so what should I do? So that they can become advocates for their own well-being.
Here comes the role of like good touch, bad touch. That is taken by another person.
Yes.
So many times she told us. She
has told so many experiences
to prevent the child from sexual abuse
which
or any kind of abuse, like bullying in the school. Right? Okay. Let's move to the next question.
As far as good touch and bad touch is concerned, you'll be surprised that the child should be made aware of this good touch and bad touch by the age of 2 years. So that's part of early childhood development. The child should be made aware of the genitalia while bathing, and by the age of 2 years, one should be aware of good touch and bad touch. So that's an important aspect of early childhood development also. Yeah, parental education has to be done for that.
So one thing I want to add, if we suspect any change in behavior of the child,
if we suspect if we see any sudden change in behavior of a child, then we should be very careful about the child who is taking care of her.
If the child is fearful,
if the child is full of fear, so we should be very much careful at that point of time. That is a very important.
That can happen only if you take care of the child properly.
Yes, sir. We should spend.
छोटी activities को notice करें. उसके साथ खेलने में
We should spend, even after we are very much busy, we should spend at least 1 hour quality time with our child.
There are so many cases of like school went there. One or two questions only. Chadar sir, how do socio-economic factors influence the health of children? That's an important part. And what strategy can be implemented to address disparities in access to healthcare and resources?
See, our country is very diverse. We have poor people, we have affluent society, we have people who have got so much of privileges. But the whole country has to look forward for upliftment in the socio-economic factors, which will influence the better housing, better education, and better cognitive abilities. These things have to be enhanced, and once our economic status of the whole country, then only the difference will be. There are people who can afford everything, and there are people not even the basics. So it's very difficult to control, but definitely over the last so many years, the socio-economic status is going and increasing day by day. And I think healthcare facilities are now reaching the rural areas every day. So that is how this socio-economic status.
Very, very, very. So, one more question for Dr. Vedi sir. How can community and policymakers collaborate to create environments that support the physical and mental well-being of children, including access to nutritious food, safe playgrounds, and green spaces?
The community and the policy makers can come together to create an atmosphere where there should be access to fresh agro-produce, where the children should have access to safe paths, safe recreation areas. This is more of theoretical. It is, although it is coming into practice, but we can think of something good, and we will definitely attain good results. And at the same time, the authorities and the policymakers should formulate and implement policies which advocate and which restrict the use of unhealthy food and beverages, at least in the schools, and if possible, in the public areas. It is more of a theoretical aspect, but still, if we think of this, we can definitely do something good for the society and the children.
So our country has done quite well. Hello India program by the government is very, very good. Food for midday food has improved a lot. A lot of private NGOs are giving good food, and environmental spaces, no cut trees zones.
Shri Ramachandra Kripalu Bhaj Man Haran Bhav Bhaya Darunam Nava Kanjalochana.
They are not showing up or not showing the result. But I'm sure these initiatives will do well.
Yeah, but it has been thought of.
There's a NASA picture which shows that in the last decade, India and our region has done quite well. But I don't agree with a lot of things because the onus lies on us to make our children sensitive for green spaces, for tree planting.
We should have a play area in the clinics, in the hospital also.
So the onus lies on us, and I think we should be doing all that, and all those initiatives are very important.
So बच्चे के बर्थडे पे उसे पेड़ लगवाइए rather than that is very.
मैडम आप ओपन फील्ड बच्ची का अभी सोसाइटी के मैसेज पढ़ रहा था कि बच्चों के केले को ऑब्जेक्शन लगा रहे हैं और लिख रहे हैं बच्चे एक लिख रहा है बच्चे कहाँ खेले एक लिख रहा है कहीं भी खेले लेकिन हमारे घर की चीज के ना
So the simple rule is charity against
I can go on debating. Even a terrace can be very green.
आप ये ना IAP की वर्कशॉप अपनी सोसाइटी में करवाइए, हम बताएंगे उनको।
One thing very clear, the last over the 15-20 years, outdoor games, outdoor activities for the children are zero. Nobody is involved in any outdoor game, everybody is involved in either
responsible
parents. And as far as sitting nutrition is concerned, a word about the sweetie and smartphones.
Sanjeev, I don't agree with it. Outdoor activities are improving. Look at India doing very well in all the sports.
Yes.
So कैसे अगर outdoor activity नहीं होगी तो कहाँ से इनकी
Well, people are more aware. They are taking the
outdoor activities are improving.
and
Now it is onus on us.
yes.
Yeah.
But everything in the schools is managed. The teams of the school, the playground, the evening game times of the school, everything is managed.
They take care.
Sweetie and Zomato access to the children, very simple.
IAP recommends 1 hour of physical activity, 3 proper meals, and 8 hours of sleep. This is a very good recommendation. But as far as adolescents are concerned, are they having 8 hours of sleep? Are they having 1 hour of physical activity? Are they having 3 proper meals with the pressure from the peers and from the parents and from the teachers?
Over-dependence on meals and outside is also affected.
Now I think we are having 8 meals and 1 hour sleep.
Sir, the sleep, 8 hours sleep and the timing of sleep is also important. They sleep at 4 a.m. in the morning.
Last question to Dr. Aranda. Last question only. Dr. Aranda, in what ways can public health campaigns and educational initiatives effectively promote healthy behaviors and prevent childhood obesity, substance abuses, and other prevalent health issues.
Public health campaigns and educational initiatives. Their job is to promote awareness among the children, among the general population about what the healthy behavior is, what healthy nutritious diet should they take, what is the importance of regular exercise in our daily routines, and what is the negative impact of substance abuse on our health. So by using the media, by using school-based programs, by using community partnerships, the IIT body of Agra is already doing a great job on various days like World Obesity Day, World Hypertension Day, by educating people in parks, in school-based programs. Man is doing such a great job on Good Touch, Bad Touch by creating awareness, and it is a very applaudable job. So,
I want to really emphasize that the parents have to be role models, because all these young couples who are into hookah, substance abuse, how are they going to, educate their children?
My mother used to say,
we need to really make them aware. All the young couples, 100% of them.
And my mother used to say, what आप जो देखते हो वही आप सिखाने से कभी नहीं.
Yeah.
So I think it's good that thank you very much. Thank you very much for the presentation.
Thank you so much, our esteemed panelist and moderator, for sharing your knowledge on such an important. Now it's time to felicitate our privileged speakers and panelists. For this, I would like to invite Mrs. Sarika Modi and Vikas Bhatia to express their gratitude for this informative CLE on behalf of MERD Foundation. I would like to invite Dr. P.P. Sharma sir.